to review the process and report on the implementation based on Senate Bill 2317. And we welcome the representative from the State Health Department. And for those in the audience, as well as legislators, the presentations and handouts today are generally linked, and you can access them through the legislative website. And whenever you're ready, please introduce yourself and begin.
Thank you. Good morning, Chairman Kaiser, members of the committee. My name is Monty Engel. I am the Director of the Division of Life Safety and Construction for the Department of Health. I'm here today to provide an overview of the Department's health care facility construction and renovation plans review process and report on the status of the implementation of Senate Bill 2317. The Department's health facility construction and renovations plan review process program is responsible for plans review and monitoring of construction and renovation projects in hospitals, nursing facilities, and basic care facilities.
Monty, you have activated the mic. Press that button.
It's blue.
It's blue, okay. All right, thank you.
Do you want me to talk louder?
No, just pull it a little closer to your phone.
Construction standards have been established in administrative code as references for the acceptable design and completion of construction, remodeling, and installation. These construction standards were updated to comply with more recent national standards in July 2015 and at the request of the regulated community. The Department of Health employs 4 full-time positions and 1 part-time temporary employee to work in the program. 3 of the full-time positions and the 1 part-time position have a background in architecture, and their main role is to review plans for compliance with construction standards. There's also 1 full-time position dedicated to on-site construction inspections. Senate Bill 2317 required the construction plans review program to implement a process which prioritized construction, renovation, or construction and renovation projects less than $1 million, excuse me, and ensured the reviews were completed within 60 days of receipt of a complete application. This priority was implemented when the bill was signed and so far has impacted approximately 15 projects. All of these projects were reviewed within the 60 days.
Monty, would you like questions as you're going through your presentation?
Doesn't matter to me.
Well,
however you would like to proceed.
Monty, so when you say that these projects were reviewed, were they approved within 60 days?
How
long did it take for approval? Because that's when the project can be implemented.
I don't know that I have that information in front of me. I would say the majority of them were probably approved within the 60 days, but I can't guarantee that all of them were. The way the legislature, the bill read, it was an initial determination, which our interpretation meant our initial review within 60 days. And so that's how we proceeded.
Mr. Chairman.
Representative Casper.
Thank you, Mr. Chairman. Monty, in the committees I serve on, I'm not familiar with this. It's more in the health committees, I believe. But I have a couple of questions. One, you referred to 40 projects, but I don't see any data at all about the projects. I don't know where the projects are. I don't know what facility it's impacting. I don't know what the dollar amount is there on each facility. Is it possible to provide the committee that data?
Mr. Chairman, yes it is.
Okay, and then following up on Representative Kaiser's question, if you review a project, what is the next step to going to the point where it can be implemented by the people who projects you reviewed or provided determination, and how long does that take?
Mr. Chairman, I'll kind of work backwards on that. How long it takes, in many cases, depends on what's found during our initial review. As the project comes in, once the reviewer gets it, they're going to review for compliance with the standards. So they're going to identify any issues of non-compliance with those standards. Once our initial review is completed, those findings will go back to the design team. Then it's their responsibility to provide an acceptable response as to how those will be addressed. And that portion, obviously, is not under our control whatsoever. So that may be days, weeks, or even months before they get a response back to us. Then at that point, we need to evaluate whether that response is acceptable or whether it complies with the standards. And it may take another couple rounds for that to get to the point where we can approve the project.
The goal is to approve the project, is that correct?
Mr. Chairman, definitely. The goal is to approve the project.
Senator Lee.
Mr. Chairman, Mr. Engel, I recognize the challenge in the time for you because of needing staff to do all of this work, and I also recognize the challenge of the facilities that are trying to take advantage of construction seasons in our wintry state. But with the new projects, the smaller ones, the ones under $1 million that were addressed by that legislation, obviously that meant that there was a priority there that was established. So how has that affected the ongoing work with these really big projects, since we've got so much stuff going on in North Dakota right now? It's okay to say if you are short-staffed in order to accomplish what has to be done on the pace that we want it done, because we need to know that. Otherwise, there's no way you can succeed in accomplishing what we hope to have done here. So I'm just curious about how that's all shaped.
Okay. Mr. Chairman, Senator Lee, yes, the legislature established a priority for us, and we still have the same number of staff we had before. So obviously the priority is any project less than $1 million. That goes to the head of the line. That in many cases means that if we're in the middle of review of a larger project, that review may halt while we focus on one of these smaller projects to get those out. And so as far as do we need staff, I'll just say I agree with what you say.
Continue.
Thank you. And I get that, and there's not much we can do about changing appropriations right now, obviously. But do you have any suggestions? Because it's really a big deal also, I know, to the, and nobody has contacted me about this, I might mention that. But if you've only got so many people, and we have now stuck the small projects up there because they weren't getting the attention they needed because of the big ones, and now we have to shift from the big ones to the little ones. Do you have any suggestions about how we might enable you to handle this? Obviously, staffing is the issue. It's more, but if it's more than that, can you tell us what we might be able to do together to make this work better?
Mr. Chairman, Senator Lee, further on in my testimony, I alluded to that, but the legislature did place $80,000 in the department's budget for a temporary plan reviewer position. So far, we've been unable to fill that position. We've also looked at the possibility of seeking outside vendors through an RFP process to see if we can get some assistance that way. That process is still in the development stage, so we don't know whether or not that is going to be successful. And so if one or two are not successful, choice number 3 obviously is more full-time equivalent positions.
Continue.
Thank you. Okay. We currently have 4 large healthcare facility projects that are under review. These include 3 big placement hospitals and 1 replacement nursing facility. Construction costs for these projects alone total approximately $500 million. The design teams for these projects have divided them into 3 to 5 smaller packages to submit for review. Currently, we received a total of 13 of these packages for these 4 projects and expect to receive 2 to 3 more. We've completed initial review on 11 of the 13. In addition to the 4 large projects, we currently have 12 other projects in hospitals, nursing facilities, and basic care facilities that are under review, and an additional one that for review has not started. Senate Bill 2317 also permitted the department to approve a request for a waiver of state law or rule relating to an innovative construction renovation or construction and renovation project if the lack of compliance does not adversely affect healthcare or health and safety. In response, the department developed an internal policy procedure that went into effect July 15th of 2019 to address the application for an innovative construction renovation or construction and renovation project. As part of this process, a waiver application form was also developed. These documents are available on our website. To date, no applications for an innovative construction renovation or construction and renovation project have been received. In addition, Senate Bill 2317 permitted the department to waive all or a portion of a basic care facility license standard if the department determined the lack of compliance does not adversely affect health or safety of the residents. In response, the department developed internal policy and procedure June 14th, 2019 to address the application. And as part of the process, we also developed a waiver application form. These again are available on our website. To date, 5 applications to waive basic care facility construction standards have been received from 1 basic care facility, and these applications are currently under review.
Monty, we have a question, Representative Wise.
Thank you, Mr. Chairman. Monty, I guess I'm curious why you felt it was okay to just do it as internal policy instead of administrative rules on these. What was your decision process there versus having input from the regulated community, just developing your own policies on that part?
Mr. Chairman, Representative Weiss, I guess we felt we could, the direction of the legislature was clear as to what we needed to do. A policy and procedure is no more than how we need to ground rules for us, and that's really something typically that you don't see in administrative rules is state government regulating itself. So we felt an internal policy procedure would handle it along with the application.
Well, Monty, well, let's be honest and open about this. There has been expressed serious concern amongst legislators that you went through the policy route versus administrative rules, given that it was based on legislation, and that this creates let me ask the question a little differently. Having said that, just so you're aware, the legislature is not overly happy with that strategy. But as a policy, is it easier to do what they are trying to do in the field, or is it more difficult? Have you placed more hurdles in their way with the policy, or have you streamlined it and removed hurdles?
Mr. Chairman, I guess it would be my opinion that we've made it easier. Also, we accomplished it quicker than we would have been if we went the administrative rules process. But I guess I feel that it's more streamlined and easier with the policy.
Well, I can assure you, Monty, that every department would like to do policy versus administrative rule. All right, continue.
During the legislative session, an additional $80,000 was added to the budget for a temporary plan review position for the department. Funding for this temporary plan reviewer provides an hourly wage plus health care benefits. Since it's temporary, no paid holidays, sick leave, vacation leave, or retirement benefits are provided for the position. The position was advertised from April 4th to April 19th of 2019, and no applications were received. A second announcement was advertised May 13th to May 31st of 2019 in the 4 major newspapers in the state, and no applications were received. A third announcement was advertised from June 27th, 2019 as open until filled. HMRMS has since adjusted the end date to October 15th per their new posting policy. We received 2 applications from this posting. After attempting to schedule an interview with the first candidate, they ultimately withdrew from consideration due to the temporary status of the position. Even though the second candidate did not appear to meet the minimum qualifications for the position, we decided to proceed with the interview. After the interview, it was the consensus of the interview team that the candidate did not have the technical skills necessary to perform the duties of the position. Therefore, the candidate was not offered employment. The position continues to be advertised through October 15th with hope of filling with a qualified candidate. The department is also considering the use of outside vendors who could assist with review of construction, remodeling, and installation projects. We are currently working on developing a request for proposal to obtain qualified vendors who would have the knowledge and ability to review the entire scope of a healthcare facility construction project. This would include architectural, civil engineering, mechanical engineering, and electrical engineering portions.
Excuse me, question. Senator Royce?
Thank you, Mr. Chair. Monty, with that last statement there, have you had the opportunity to talk to, like, I'm thinking about some of the major architectural firms who work on healthcare design and find out who are some of the vendors that are utilized in other states, so you know where to kind of focus your energies there? That makes sense.
Mr. Chairman, at this point we have not spoken with those. We're still working through the development of the RFP, so I expect to do that when we've got an RFP.
Awesome. I encourage you to do that. Thank you.
The department has heard concerns over the timeliness of the plan review process. To address this concern, we're attempting a multi-pronged approach. First, we'll continue to attempt to bolster the program with additional temporary position as provided by the legislature. Second, we will continue to explore the innovative approach of utilizing qualified outside vendors found through the request for proposal to aid in the plan review and provide facilities an expedited route to their plan review process. If those options prove to be unsuccessful, we would examine if there's a way to potentially add additional full-time equivalent positions for the program.
Senator Banner?
Mr. Chairman and Mr. Engel, do you believe if the Emergency Commission and the Budget Section were able to change the position from temporary to a position that had benefits, do you believe you could fill that position with that change?
Mr. Chairman, Senator Matthew, yes, we feel confident we would have a much better shot at filling the position if it was a full-time equivalent position rather than a temporary position due to the added benefits that we would provide.
Okay, thank you, and Mr. Chairman and members of the committee. Mr. Engel, I understand in most of these projects there are architects, engineers, professionals that are licensed, that are designing these facilities. And the standard of design is really a public standard that they know and you know. There really is no secret about you have different rules than
and the national standards. You're looking at the same standards. When there is this discrepancy, are we really talking about incompetence or illegal behavior on the part of professionals? I mean, if a professional who is required to follow the standards comes up with a plan that does not meet that criteria, isn't there some action there that the profession should be reviewing? And I'm just wondering if this is ever reported to the professional bodies that a plan came in that does not meet the national standards. Is that a matter of discussion either in your department or amongst the entities building these projects?
Mr. Chairman, I don't know. Occasionally, there's discussion about the thoroughness of the design. As far as going the route of incompetency or something like that, whether it be a professional engineer or registered architect, we have never reported anything to either of those governing boards for something like that. I have a hard time saying they're incompetent. I will acknowledge that the standards are there for anybody to read, and you shouldn't be designing without having those standards in front of you. And many times it's disappointing on the quality of the projects that we do receive. But I don't know that I'm in a position to be pointing fingers at them and determining their level of competency.
Representative, continue.
Mr. Chairman and Mr. Engel, in a way though, we're putting you in a position to decide whether or not the architect has done their work properly. I mean, that's why you're reviewing these and you're deciding. I just wondered, Mr. Chairman, if we should look at that variable at some point, because these are registered professional people coming up with the design according to this national code. It should fit the code. Or there's maybe a way that we could get those parties closer together before we even get into review standards. Thank you.
Representative Blythe.
Well, thank you, Mr. Chairman. I guess slightly on Senator Mather's take. We assume they're competent. Same with your staff. So is it oftentimes just a matter of a different interpretation of the standards and what they say versus somebody being incompetent versus somebody being competent? Because certainly these $500 million of projects hire competent architectural and engineering firms. So often does it just boil down to a difference in interpretation of what the standards really say between, say, your office and whoever's designing the project?
Mr. Chairman, that certainly is a possibility. For the most part, firms that are designing in the healthcare field are competent, they're experienced. Our people are competent and experienced. If there is a question of interpretation, the expectation is that the design team would be reaching out to us. As laws are set up, it's our responsibility to be interpreting the intent of the standards that have been addressed. So if there's a question of interpretation, they should be addressing it with us.
Senator Dillon.
Thank you, Mr. Chairman. Monty, I might be able to help you out here. Several interims ago, we had this same discussion. And as it turned out then, the problem wasn't with compliance with city and state building codes. but rather with CMS standards that seem to be ambiguous and constantly changing. So is that still a concern, and is that part of this issue?
Mr. Chairman, I don't think it's a big concern of ours at this point in time. Obviously, CMS has the ability to interpret the standards how they want them to be interpreted, and we're going to need to follow along with those. But I haven't experienced any recent issues that have affected design or things to be out of left field or anything like that.
What seemed to be the part of the issue at that point was inspections as the project was proceeding. And there were changes made from the original plan necessary by changes dictated by CMS, as I recall.
Mr. Chairman, the reason this program grew about 10 years ago was out of some issues that had occurred where we reviewed the plans and approved the plans, but had no ability because of staffing to go out and monitor construction to determine whether or not the buildings were being built according to the plans. And so that's where things fell apart. We reviewed a project, it met the standards, it was not built according to the plans, and then we get out on site for CMS surveys at a later date and find non-compliance. And so that is, in a nutshell, what made this program grow probably, I don't know how many sessions ago, but probably about 10 years ago.
Senator LP?
Mr. Chairman, it kind of makes me think about some of the contractors I work with and how they complain about their DOT projects that they're working on, because those doggone district engineers, they come out and they're checking on them all the time. They want to make sure that the finished product is right. But just because an architect designs something doesn't mean that it's going to get built that way, depending on who's watching and who's checking. And, the contractors would like to get paid at the end of the job and not have to go back and tear out and do it over. So to have someone there following it or approving the plans ahead of time, I think is just a great idea. We do it all the time with our road construction across the state, and you wouldn't want it any other way. Certainly our ag folks that are, in the room or across the state wouldn't want to have roads that may or may not hold up if they are driving on them. So I think it's a good program.
Continue.
My presentation
Okay.
is
Any further questions? Representative Gasper?
Thank you, Mr. Chairman. Marty, just going back to page 1 of your testimony at the bottom of the paragraph, you state that your employees have a background in architecture. Are any of those employees licensed architects, or what are you meaning by a background in architecture?
Mr. Chairman, one of the full-time positions and the part-time position are both licensed and have their license as an architect. The other two do not have a license. They're eligible to take the test, just have not done so.
And that's credentialed here in North Dakota?
Mr. Chairman, yes, that is correct.
Thank you.
Further questions? Monty, is it the case that if a healthcare facility is starting a project, they cannot implement that project until the health department signs off? They can't implement part of it, or is there a procedure that allows them to do incremental approaches to their project?
Mr. Chairman, I'll give you a short answer and a long answer. The short answer is state law says that you cannot begin construction without our approval. So how we've encouraged, especially large projects, to deal with that is, like I referred to in my testimony, to break it up into packages. Like for large projects, we might get a package in for the footings and the foundation. There might be another one for the structural steel, might be another one for the exterior envelope and the roof and that type of thing, and then the interior fit out. That allows them to get going on the project without having the entire project approved.
But in terms of starting their program, whatever it is, not only do they have to have that approval to start the construction, et cetera, you have to sign off at the end to say this has been approved as an approved project and it can be implemented. Is that correct?
Mr. Chairman, yes. There's probably a couple approvals in there because we need to approve the initial design for compliance with the standards that allows them to start construction. And then we're going to be monitoring construction as it goes along and along with all the changes. And then at the end, when they're ready to occupy, we're going to need to sign off again to allow them to occupy the building.
And in addition to construction, do you look at the program they're implementing? Let's say a neonatal intensive care unit is going into a hospital. They don't have one. They're going to construct a new wing or whatever, and they're going to hire the staff. Do you sign off on just the physical structure, or do you sign off on the program as well?
Mr. Chairman, our office would be strictly looking at the building. The Division of Health Facilities would concern itself with the program or the services offered for whatever service it is. So we would coordinate with them if there are questions during the design and construction.
Representative Nelson.
Thank you, Mr. Chairman. Monty, I noticed on your website that there's ways to apply for waivers. So what sort of things can they apply for waivers, and how do you operate the waivers?
Mr. Chairman, there are two different types of waivers that were provided in Senate Bill 2317. One says an innovative review process. So if it's something that may not be addressed by current standards because it's innovative, we could certainly look at granting a waiver to do that. The second process provided by Senate Bill 2317 was for any licensing standards dealing with a basic care facility. And that leaves it pretty well wide open to anything that a basic care facility would need to comply with in order to get a license from the department, whether that be building or program issues.
Okay, thank you.
Further questions? Thank you very much, Monty. But before you sit down, and I realize that the legislation was enacted, 9 months ago or whatever, and it became law even later than that, but you knew about it coming. So would you provide the committee, not at our next meeting, but perhaps in 6 months from now, with a report with actual data in it, looking at prior to this new implementation, this program you're implementing now, how long, when requests were first received, how long until they were reviewed on average, how long until they were approved to proceed, and compare that with the data from your new program so we can see whether or not, in fact, this is facilitating and addressing the concerns expressed during the session.
Mr. Chairman, I'd be happy to.
Well, thank you very much. Senator Lee.
Thank you, Mr. Chairman and Mr. Engel. It seems to me that this RFP process is probably going to be your ultimate solution. I can't say you're going to decide that for sure, but it seems to me that those folks that are in that business now and who do these contracts on a short-term basis or whatever are up to speed pretty much the first day. And when you hire someone, even if you're able to find someone to fill that temporary position, there's going to be some training involved as well. So with that thought in mind, if you decided to kind of focus on the RFP part, since we haven't had much success with the other one, how long would it take for that to sort of hit the ground so that you could get the RFP out so that we might see this we're in September, this is kind of a big deal with some of these outfits, get their work on. So tell me how long it would take to get action here on the RFP process, if that's what you
Mr. Chairman, Senator Lee, we've got the RFP maybe 50% written, so maybe another month we can get to the street, hopefully, if all goes well. And like I said, at that point, we'll wait and see if anybody responds to it.
Thank you.
Any further questions? Thank you very much, Lonnie. Is there anyone else here that is interested in testifying on this segment? Shelley, welcome.
Thank you.
Whenever you're ready.
Good morning, Chairman Kaiser and members of the Healthcare Committee. Thank you for the opportunity to testify this morning. My name is Shelley Peterson, President of the North Dakota Long-Term Care Association. We represent 212 basic care, assisted living, and nursing facilities in North Dakota. I would like to briefly address the waiver provision for basic care contained in Senate Bill 2317 and some brief comments on the role of the Health Department with healthcare construction projects. Regarding the waiver, Basic Care wants and strives for buildings that are safe and protect residents and staff. We were excited to see the changes in the Basic Care waiver language outlined in Senate Bill 2317. It has one very important requirement. You must show the rule being waived does not adversely affect the health or safety of residents. If you can prove that, the waiver should be granted. We anticipated the rules would change because the current administrative rules are not congruent with the changes outlined in Senate Bill 2317. The current rules contain 3 requirements, not just the one outlined in Senate Bill 2317. The 3 existing requirements state a waiver must be for a specific period of time in a specific instance. You must prove unreasonable hardship, and you must assure the health and safety of residents, which is the one requirement in Senate Bill 2317. Rather than adopting new rules which require a public hearing process, the department developed a policies and procedures manual and posted it on their website. The policy and procedures manual outlines numerous requirements. 4 examples are it requires an additional step of seeking DHS approval on the HCBS rule. You must show financial hardship, unreasonable hardship, and it also states that all health department decisions are not appealable. It keeps the language of specific periods in specific instances. We felt the new process lacked transparency. When inquiring about the rules, I was told the policy and procedure manual was final and posted to the website. I was requested to refer basic care facilities to the website if they plan to submit a waiver. We are hoping to have a voice at the table to work with the department on rules to implement the revised waiver process. In the spirit of transparency and complying with the intent of making waivers a viable option, we recommend the health department go through the rulemaking process. Regarding the construction projects, we look forward to the study regarding the health department's role in reviewing and approving basic care, nursing facilities, and hospital construction and renovation projects. Over the years, we have worked closely with them to improve the process and address provider concerns. The number one concern has been the delay in project approval. As you can imagine, with our short construction season, which you've already discussed, everyone is anxious to get started with their project. In these high demand times, the health department has put in additional resources to meet that demand. In 2009, and I was impressed with Monty when he said about 10 years ago, because it was exactly 10 years ago, periodic inspections began with the goal of reducing the non-compliance of buildings at the end of a construction period. It used to be you received approval to begin your project, and then at the end you had an inspection to assure the building met all the standards. Unfortunately, in too many instances, the building was not compliant. It was a variety of issues causing non-compliance. Contractors didn't build to the specifications, The health department missed something on the plan review, subcontractors substituted a door, a number of issues. The periodic inspections, as Senator Elke talked about too, are helping make sure that the buildings are in compliance at the beginning of the project and at the end of the project. I think the key factor in making this program work has been the collaboration of the health department and health providers working together. We appreciate the opportunity to work with you and the health department to assure that we have safe and compliant healthcare facilities and timely construction plan reviews. The legislative study that you're undertaking now will be helpful. And on the health department's website, they do have a list of all the projects, when they were submitted, if they're under review, and the time frame. So all of that is readily available on their website. And since they started publishing that, that has been a really helpful document for everyone, because when you put your project in, you're hoping for approval right away. With that, I would be happy to answer any questions that you may have.
Questions, Senator Maverick?
Thank you, Mr. Chairman. And I've been following this in some detail with some projects, and I've wondered about the fact that they all look at the same standards. What is your view of professionals that are licensed actually being competent to follow those? I work in a hospital situation, and if there are other professionals that don't follow what is required, they don't get paid. I'm just wondering, in your industry, when somebody designs a building and then the department finds that it's not compliant, do you still pay those people?
Mr. Chairman, Senator Mather, and other members of the committee, generally we find that facilities do hire competent licensed contractors, architects, engineers, and many times it's an interpretation of that regulation, or that this material met the same standard and there was a substitution because the material wasn't available. All change orders are supposed to go to the health department. If every single change order on every single project actually went to the health department, they would never get their work done. So what we're finding is many are not putting in change orders, and that would be nice to have in the study. Is it feasible and possible? And maybe that would help cut down on it, but we find that there are competent people. The greatest area of variance, we believe, is caused by an interpretation of a regulation. The standards, you would think the healthcare construction standards and or the life safety standards that we must comply with are black and white. But many times they're not black and white. And we've gone to CMS and to our national affiliate on an interpretation of a standard and have gotten different interpretations and have gone back to the health department to resolve the issue. So it's not as black and white as we would like it to be, but for the most part, I believe we hire professionals that submit plans, and part of the discussion we've had in the past is, since we believe we're hiring competent people, hospitals are hiring competent people, should it be on us? And if the building's not in compliance, then you don't occupy the building until it's done, rather than go through this review process. Would that be a better process rather than having this review that takes from 2 to 6 months? And maybe that's something we should look at, because we feel we are hiring competent people. But we have immensely liked, since 2009, the project that they'll go out and do intermittent inspections. That has helped immensely. They can look at the wall while it's open. You don't have to tear open a wall. They can look at the standard on the material you're using. It has helped immensely. But I think for the most part, we absolutely are hiring competent people.
Mr. Chairman, I very much support the review process in terms of while construction is going on, and I was a part of development of that. But I have actually seen where blueprints are offered and found non-compliant to the actual standards. So it's not just somebody put in a different door in the project, it's actually plans before construction that are found non-compliant. It seems like, and the finding then that it should change would seem to indicate proof that it wasn't there, or somebody would take it to court, because there's hundreds of thousands of dollars here involved. You would think if the competent architect said they were actually correct, the state was wrong, why don't they take it to court? I mean, it seems like they generally say, yeah, you were right, state, we should have changed that.
Mr. Chairman, Senator Mather, and members of the committee, I know at the Veterans Home there was an issue on their building project. I don't know if that's the one you're alluding to. But generally, as you look at that plan review and the architectural plans, there's never a project, although Monty can correct me if it has ever gone through 100% the first time. There's always a question, there's always an issue. So it's not as black and white as we would hope it, but yes, absolutely. If you have someone that submits a plan that is not compliant and the whole thing is, a disaster and is not meeting or understanding the standard, I agree with you. I mean, it's been a waste of time and money for everybody.
Thank you.
Senator Lee?
Excuse me. Shelley can perhaps correct me if my memory isn't totally perfect on this. An example of two good comparisons that weren't in sync when what now is Touchmark in Fargo was built, which is a very nice facility. They put in the sprinkler system that was expected by the city of Fargo building codes, which was a top drawer system. The inspectors came through, and it turns out the federal rules, I believe it's federal, said it should be a different one, which was not as new, not as good. And they had to take out the better one to put in the other one in order to be compliant. I'm not blaming this on the state health department. I don't think it was their rule. But my point is, both of them were sprinkler systems. They had to tear out the new sheetrock in the ceilings. They had to do all the sprinkler system over again, obviously delay occupancy. And so part of our issues, I think, maybe, and please comment on this, whether or not some of the federal rules are not exactly, they're not able to keep up at quite the same level as our local contractors and architects and, excuse me, and facilities developers might know.
Mr. Chairman, Senator Lee, and members of the committee, we've had some issues with, Touchmark is an assisted living and basic care facility, so the healthcare standards of their assisted living portion and their basic care portion are different, unfortunately. So we've had some issues on buildings that have multiple different types of license and the standard. They built that building to comply with the building codes in North Dakota, but then when you do basic care, you bring in the life safety code for the basic care portion. And so yes, we've had those issues and we've had those differences. And today those issues are continuing. The one that has a waiver project in now is a basic care facility. They have assisted living, and the standards changed dramatically in 2005. So some have built their buildings on standards before 2015, and now they're building facilities after 2015, and the life safety standards are completely different. And so we're having difficulty, and that's why we see this waiver as very good, because it's still the health and safety of the residents must be assured no matter what we're doing. And there are some rules that don't make sense and that we can do just as safe with a different process. So that's why the value of the waiver is so important, because of that issue that you just described.
Representative Dover.
Thank you, Chairman. Ms. Peterson, excuse me, on the bottom of your first page, you talk about requirements. Give some examples of requirements that are in the policy and procedures manual. And the idea of something not being appealable is kind of disturbing to me personally. And I'm just wondering, prior to this policy and procedures manual, could facilities appeal? Was there an appeal process?
Mr. Chairman, Representative Dobrovich, and members of the committee, yes, generally there is an appeal process. If you look at, there is a link on Monty's testimony to the 3 pages of the policies and procedures, and it states the state health officer or designee will make the final determination related to the approval or denial of the waiver within 60 days of when the completed waiver request was received. The final decision by the state health officer designate is not appealable. So yes, when I, when I read that too, I was stopped in my tracks because it just, the process is complex. It's much longer than we've ever seen. And not having anything appealable just seems foreign to me.
Thank you.
Representative Hogan.
Thank you, Chairman Kaiser and Ms. Peterson. Basic care is unique to North Dakota. And these rules are written by North Dakota. And, we often say it's a CMS rule or it's some kind of external rule. But these rules are our rules. When the basic structure was established, and do we need to have a comprehensive review of the whole role and regulation of the system as a whole? Because we're kind of dealing on waivers and all kinds of issues on, nursing standards and all kinds of other things. And so do we need to try and simplify this because of the regulatory rules? Because this is a program that is ours and we wrote the rules. Should we look at them?
Chairman Kaiser, Senator Hogan, and members of the committee, probably. I think the last comprehensive study when we looked at basic care and assisted living was when Senator Lee and there was another person said, let's look at basic care and assisted living. You're so similar. Should we be one? Why do we have this unique basic care program? Is it still working and functional? And that's been, I would think, at least 15 years ago.
Yeah.
So yes, probably, because it's unique to North Dakota. It's been a great program to meet a need, but probably review would be good to see, does it still fit the model of what we were hoping? And since it is state, all the power lies with you on what you do in many instances. So it's been a very good responsive program, but probably, yes, time for review.
And in light of the fact that we know we have an OLSID claim on long-term care, this might be the appropriate time to look at on the continuum of care how these pieces fit together. And have we become the over-regulator? So I think it's worth discussing.
And Mr. Chairman, the great value then in the waiver, because in theory it would be nice to never need a waiver because the program is responsive and meets the needs of the citizens of North Dakota, the facilities, and the public. So it would be, maybe it is time to review everything. But absent that review, and having a workable waiver process, it'll be good to see, if waivers are approved. I did meet with Mylin, and she was very open and very responsive and said, let's try to make the process work. Shelley, you're getting a little bit anxious and we haven't even started. And I may be. But when we looked at the waiver requirements and the issue on not being appealable and all the additional requirements that seem to keep in place the current administrative rule versus the new legislation, it brought concerns to the table for us.
Further questions for Shelley? Shelley, just finally, do you now and your members believe that it's more difficult than before these policies were adopted?
Mr. Chairman, members of the committee, absolutely.
Well, that's ironic, given that the legislation was supposed to expedite it.
But hopefully I'll be proven wrong. Thank you very much.
All right. Is there anyone else here to testify or to present on this issue?
Thank you again.
Thank you, Shelley. All right. Seeing no one, is there anyone in the audience that would like to comment on this issue? Committee discussion and directives. Representative Hogan.
Thank you, Chairman Kaiser. I think it might be helpful for us to get some background on the history of basic care in terms of when was the last time we did a comprehensive review of that role. Because I think that whole question is, these are all of our rules. We did all of this. So maybe we should think about it.
Senator Lee.
Chairman, I support that idea, and I guess I have a hard time understanding why the physical structure rules should be different for basic care than they are for assisted living. Maybe I'm off, but that would be one of the most obvious and simplest things, whether or not 1 inch makes a difference in the width of the hallway, for crying out loud. I mean, some of that stuff is moving. On the federal level, we all know that. But yes, Senator Hogan is right. The goal of this was to make it easier and to provide a level of care that the state could afford. It really all backs up to not wanting to have assisted living paid for by Medicaid, realistically. Remember that. So this is going to create a category for a certain population. That's sort of the American plan of assisted living, in which all services are provided for a flat fee. And it would be Medicaid reimbursable, but none of the rest of assisted living would be that private pay. I'm not arguing that point. But there are some of those things that are structural issues. I'm talking the building. And I can't see any reason myself why it should be different. Now, there are smarter people in the room than I am who may know why it should be different. But I'm really willing to listen. So I'd love to see you consider adding that to our discussion if there's something that possible.
Senator Madden.
Mr. Chairman, I would like us to follow up too with the RFP that they are talking about. I've talked with some of these facilities. They're glad to pay the fee, you know, if the department could hire somebody to look at these plans and to approve or reject, and that costs money. They're willing to pay that fee. It really is a matter of many millions of dollars when months go by, and I think that's one of the best solutions that the department can get to right away. But maybe it needs some oversight to make sure it happens as soon as possible.
Further discussion? My only closing comment, I would encourage the Department of Health, and now their representatives and leadership are here, to reconsider their actions by which they did this through policy versus administrative rules, and to do it post-hastily. If you think we're going to allow this kind of precedent to be set, you are wrong. And we will come back with a vengeance in the next legislative session, and other departments will not be happy because we'll probably overreach in our actions. So just a thought for you to consider. All right, that ends our session. And Monty, sorry to feed you to the lions this morning, but you did a great job. So thank you very much. Our committee members, it's almost 10 o'clock here, which is almost 11 o'clock in the eastern part of the country. And rather than interrupt the next segment, I would like to take the prerogative of the chair. Senator Lee suggested this. I give her full credit for it. That we just have a moment of silence to recognize the victims, the families, and the emergency responders at 9/11, and to celebrate, to honor them, and to celebrate the strength of the United States and what we stand for as a country. So if you don't mind, we'll just take a minute of silence. All right, thank you very much for honoring those folks. It's one of those days, everyone here, I think, it's one of those days that we have in our mind and remember with great detail. All right, the next item on our agenda is the study of the insurance premium trend study. We have a bill that has been distributed. You committee members, you have a copy at your seat. But prior to reviewing the bill, we have a video presentation that I think you'll find educational and advantageous. So, Jen, whenever you're ready.
Thank you, Mr. Chairman, committee members. When I get this powered on, our volume is going to be rather high.
And I think on this Wall Street Journal article, we probably have a commercial that will play ahead of time. And when I get back to my seat,
As
I
a
will
principal, I can
get
tell you
this
this.
powered up on
When
the
one
monitor.
student gets left behind, we all get left behind. This is a problem that affects each and every one of us. Together with IBM, we've created a whole new kind of school called DTech. Within 6 years, students can graduate with a high school diploma, college degree, and a pathway to a competitive job. Today, there are more than 100,000 PTech students around the world. It's a game changer.
You might think the process that determines how much you pay for something is pretty straightforward, and it often is. For example, here's the supply chain for a beverage you might buy at the drugstore, say a Pepsi. PepsiCo manufactures the soda and sends it to a retailer who sells it to a customer. The customer pays the retailer and the retailer pays PepsiCo. Simple, right? Well, that is not the case for the products behind the pharmacy counter, the drugs. Here's a typical supply chain for prescription drugs. It looks really different. That's because the way that drugs are priced is not at all a straightforward process. Experts and politicians argue that the very complexity of this chain is part of why drug prices have grown so high for customers.
Everyone involved in the broken system, the drug makers, insurance companies, distributors, pharmacy benefit managers, and many others contribute to the problem.
To understand this debate, first you should understand the flow of drugs and money within this chain. Let's start here with the pharmaceutical companies. They're the ones who develop a drug and set a price, known as the list price. This isn't as straightforward as it might look, which we'll explain in a moment. Next, you have the wholesalers who transport the drugs and sell them to the pharmacies. The patient pays the copay, and the pharmacy sends out a bill that gets paid by the insurance company. That's simple enough, but we're missing a link. The link that manages this transaction and adds a lot of complexity to the chain. Meet the pharmacy benefit managers, or PBMs. They're who the drug companies and some politicians are talking about when they refer to middlemen. They work for insurance companies, big employers, and government agencies. And a big part of their job is to bring down the cost of drugs for their employers. They do this by negotiating with pharmaceutical companies for rebates. Yep, for many of the drugs a pharmaceutical company sells, it pays a rebate to the PBM. The PBM sometimes pockets a portion of the rebate and passes another portion on to the insurance company or employer. Why the pharmaceutical company pays these rebates is the source of a lot of controversy. What happens is the drug company gets moved up on something called a formulary. So what's a formulary? It's the list of drugs that the insurance company covers, and it's grouped in tiers. Each tier represents what portion of the list price the patient pays and what portion of the list price the insurance company pays. The highest tier in the formulary is the lowest copay for the patient, and the lowest tier is the highest copay for the patient. When the pharmaceutical company pays a higher rebate, the PBM will move the drug up on the formulary. Pharmaceutical companies want high placement on the formulary. That's because patients are more likely to take the drug that's most affordable, and that usually means higher sales for the pharmaceutical company. If a patient wants to take a drug that's lower down on the formulary, or not on it at all, they have to pay higher copays, or even the full list price of the drug. If this seems confusing, that's because it is. Let's take another walk through that transaction, this time with an example. Say a hypothetical drug costs $100. A PBM negotiates a $50 rebate, $10 of which they pocket, and $40 of which they pass on to the insurance company or employer. In return for that rebate, the PBM moves the drug to a better spot on the formulary, making it cheaper for the patient to buy the drug. This transaction is important because the pharmaceutical companies say it's a big reason they keep raising the price of drugs. You've probably seen a chart like this before. It's the rise in the price of a drug in the U.S., in this case, Humalog, according to its maker, Eli Lilly. The pharmaceutical companies say they have to raise list prices to protect their sales and profits from the demands of these higher rebates. Here's the CEO of the pharmaceutical company Merck at a hearing on drug prices.
If you bring a product to the market in this system, you get punished financially.
Here that different people, different insurance companies pay different prices for the same drugs. As you can see, the way that prices work behind the counter is totally different from how they work in front.
All right, there will be a test on that shortly after the recess. But I hope I gave you a very quick overview of kind of the process. I know legislatively, especially with Representative Casper in the House, but there's probably a counterpart in the Senate, who've been extremely active on this issue, specifically PBMs in the past. So Representative Holt, or Senator Holt.
Thank you, Chairman Kaiser. Can we get a copy? Jennifer, can you send that out to us? Because I think it's such a clear explanation of the issue that we might want to share it with our colleagues.
We can certainly do that.
I think that'd be really helpful.
All right. So, as was discussed at the last meeting, and I've been in the legislature for a while. I cannot remember any other interim committee I've ever served on that has bill drafts in their second meeting. But we do have bill drafts for you this meeting. And the first of these is 21.006.02. This is the drug transparency bill that we talked about at the last meeting. This is modeled after the Texas drug transparency bill. And we have attempted to make modifications to it based on our current statute where appropriate. And I'm going to ask Jennifer to kind of walk through it and explain it to the committee members and members of the audience.
Thank you, Mr. Chairman, committee members. Going over 21.6.02. The first thing I'm going to do is give you a high-level review of it, and then we can go through the bill itself and go section by section. The way this is written is it's administered by the Board of Pharmacy with a little bit of cooperation from the insurance department. We're requesting data from 3 different entities. We're requesting drug data from drug manufacturers, PBMs, and health insurance carriers. Once that data is reported to the Board of Pharmacy, the Board of Pharmacy has an obligation to, within 60 days, to publish that on a website that they maintain. And failure of these 3 entities to comply with these reporting requirements results in a criminal penalty. This is listed as a Class B misdemeanor. So that's our high view. We can work our way through it. The first thing we do on page 1, section 1, we're creating, let me back up, we're creating a brand new chapter to Title 19, which is our food and drugs chapter. So that's may be familiar to you. That's where most of our PBM regulations sit. Our first section is our definitions. If we're going to define a term, we're going to use it. So we define the board as the Board of Pharmacy Commissioners, Insurance Commissioner. Concession, which is, I believe, a definition that's unique to the North Dakota version. In preparing this, you'll notice this is a 2000 version. We did work with some of the stakeholders to get their input. So we've got a new definition of concession. We've got a definition of drug, definition of health plan and health insurer. We've got a definition of net spending. We've got a definition of pharmacy benefit manager. Our definition of pharmacy benefit manager, we use the definition that we have, as I noted, this is in Title 19 where we've got our pharmacy benefit manager regulations. We're using that definition that we already used. We've got a definition of rebate, specialty drug utilization management, and wholesale acquisition cost. You'll notice on page 2, after line 20, there's a note here. We've located this in the Board of Pharmacy. An option would be to locate it with the insurance department and instead have cooperation from the Board of Pharmacy in putting this together. Looking at section 2 on page 2, beginning on line 21, we've got disclosure of drug pricing information. Remember how I talked about we've got 3 different entities that we're working on here. This one addresses drug manufacturers and their quarterly reporting requirements. You'll note it also is the first place we say the Board of Pharmacy is required to have a website where they publish this data. Rolling over to page 3, the manufacturers have a timely requirement to report increase in drug prices. And then we've got the laundry list 1 through 8 of things that report needs to include. I think on lines 18 through 20, it's interesting they need to include a statement of the rationale regarding the factor or factors that cause the increase in the wholesale acquisition cost, such as...
You might spend a little more time on 2A, on the percentages. Just so
I will.
the committee is aware.
Thank you,
Okay.
Mr. Chairman. Such as raw ingredient shortage or increase in pharmacy benefits manager rebates. And Chairman Kaiser brings to my attention, I probably should go up on the top of page 3 on lines 1 through 5. When we talk about when they're required to make a report to the Board of Pharmacy and there's a drug increase in prices, we have listed it as if there's a wholesale drug acquisition cost of 40% or greater over the preceding 5 calendar years, or an increase of 10% or greater in the preceding 12 months. And these are for drugs with a wholesale acquisition cost of $70 or more. The version that we started with, it said for a 30-day supply. We've changed that to a manufacturer packaged drug container. The rationale for that being a 30-day supply of what is going to be different for different individuals depending on their dosage. And then you'll notice I'm going to hop down to the bottom of page 3. We've got another reporting requirement for these drug manufacturers. If there's a new drug that is priced higher than the Medicare Part D program specialty drug list, they're required to make that report as well. And flipping over to page 4, that second actor who's required to report is the pharmacy benefit managers. They've got a requirement that they submit an annual report, and lines 12 through 22 report the items that need to be included in that annual report. Again, we say that the Board of Pharmacy has a requirement to timely publish this information on the website that they manage. Rolling over to page 5, we've got the disclosures required to be made by our third actor here, and that's by the health insurance companies. They've got an annual report requirement, and again, the Board of Pharmacy has a requirement that they timely publish. We authorize the Board of Pharmacy to adopt rules. We say we direct the board to develop forms for reporting, so everybody's got the same format that they're following in making their reports. And we also direct the Commissioner of Insurance to cooperate with the board in putting together in developing the forms for the health insurance carriers. And then the final provision here on lines 23 through 24 is that penalty clause I mentioned. And I'm happy to answer any questions.
Senator Elton.
Mr. Chairman, Jen, was there a particular reason that the 30-day prescription was used? You know, sometimes I hear people say, I only needed a week's worth, but they said, well, here's 30 days is cheaper, or you can get twice as many for half as much, or something like that. And it seems like now you get a feeding frenzy, and if it happens to be a drug that's, I don't know, opioid or something, then what are you going to do with the rest of them, or who's going to get them, or who, you know, is someone going to sell them?
Senator, which reference to 30 are you referring to? Can you show me?
Well, top of page 3 in that first paragraph. Not more than 30 days. You got drug with a wholesale cost of for the
on lines 4 and 5, as our model came to us, there was a reference to 30 days, and we changed that. So we no longer, in this area, in this portion of the bill draft, we no longer reference 30 days.
Okay, so we would get information on any increase no matter what, I mean, so Are we going to say we want to know what it costs for 1 pill, 5 pills, 10 pills, 30 pills, 30-day supply, or what?
Mr. Chairman, Senator, my understanding in visiting with the stakeholder as we came up with this language is typically these drugs come in a package, and whatever that package is that it's distributed in. For instance, there's a particular drug I take, it comes in a 90-day bottle. That might be one way. If you take a Z-Pack and it comes in a 1 dose, that might be a...
But you get 90 days worth whether you need 30 or not. I mean, that's what happens. It's an ongoing thing for you, I get that. But for some people, that's not the case.
And that's why we moved away from the 30-day.
We eliminated
We
30
eliminated
days.
the 30-day reference. We don't have that in this.
Okay. So, but we just have something called a package. So
Well-
that's a 90-day deal?
It depends on the drug itself.
It could be a single pill.
It could be.
It's
In a
generally
package.
standard in the way that it's sold to the pharmacy or to the hospital. There's a standard packaging from the manufacturer to that. Then the pharmacist at that location breaks it up into whatever your prescription asks
Okay.
for. So it's the standard, whatever their each is, whatever their unit of measure is, when selling it, that would be, what a case is or what a package is standard.
Thank you.
I have a couple questions as well.
Senator Rohr.
Mr. Chair, just as you were reading through, I'm not sure that we have answers to all these questions, but as you were reading, I heard one group has to report quarterly, some have annually. Is there a reason for the differences in the timelines? The second question is also, I do a lot of data in healthcare for my day job, and there's a lot of lagging data. So when we talk about deadlines, just making sure that we allow for that lagging data. So the quarter might end December 31st. It doesn't mean the data is available January 1st. Sometimes it takes a little time to process the information. So I just want to make sure whatever we write in here allows for some of that. And this is just me not understanding, but with a criminal penalty applying to a business, is it just a fine then? Because who would serve jail time if it was? I just don't know the answer to that one.
Mr. Chairman, Senator, as it relates to quarterly versus annual, I would defer to the experts, and I would tell you that this is based on the model that we looked at. I don't know the rationale in them. With lagging data, again, I would defer to the experts to find out when that data becomes available. As it relates to criminal penalties for corporations, I don't have a strong opinion about whether you keep this as a class 2 misdemeanor, but I can tell you that if a prosecutor wants somebody to serve jail time, they can find somebody to serve jail time.
And I might add that, again, I recognize the problems of the healthcare providing system responding in a timely fashion, but they're not responding. These are the manufacturers, the PBMs, and if they have an increase in that time period, they need to report it.
Yeah, I totally
And
understand.
I
I think everybody has some sort of a data lag in that you may have made the sale, but it hasn't processed through your accounting system. Is all I'm saying is we just make sure that we build in a little bit of time for them to actually create the report so that the data we get is accurate.
Representative.
Thank you, Mr. Chairman, committee members, on the lag of data. When you get to the rebates, the letter from the TCMA addresses that about the data lag, and that's absolutely correct on drug rebates. The calendar year is generally how the plan operates, depending upon the plan of the employer that has, or the plan year that the employer has. But at the end of the 12-month period of time is the cutoff. Let's just say December 31st. And then you process claims that were incurred during that period of time but have not been processed or paid, and they go into the following year. And they could take 3 or 4 months before they're paid, not only processed, not only prescription drugs, but medical claims, which are a different issue. So the date to ask for data for rebates for the previous year would be roughly 6 months into the following year, where all the data has been processed, the rebates have been paid, the insurance company gets the rebates, and then the insurance company, depending upon their contract with the employer, shares a percentage of those rebates with the employer, keeps part of them if they do. Some transparent insurance companies We'll share all of the rebates with the employer, the health plan. Some of them keep a portion of it. That's the part. But you can't get the data for the previous year until you allow that, I'd say, 6 months into the following year for the claims lag and the processing to occur.
Mr. Chairman.
Senator Madden.
Mr. Chairman, could you review for me and maybe the committee what your vision is in terms of the outcome of implementation of this for the consumer?
I can certainly give you my perspective.
Yeah.
And I'm going to preface it by saying yesterday I had the opportunity to be on a panel with the CEO of Sanford here in Bismarck, and the president and CEO of Blue Cross Blue Shield, and then the insurance commissioner. And the one thing that was common, the basic question asked was, with the tremendous increases we've had in premiums and healthcare costs, what can we do to address that? And the one, there were more than one, but the largest element of consensus amongst the panel members was transparency. I personally am extremely frustrated when I hear a physician say, I have no idea how much the drug costs my patients that I prescribe. I have great concern when I know some of the things that PBMs have in the past engaged in. What this is attempting to do is to begin to bring transparency to the marketplace and justification for it. The key to this legislation, the most important element for me is, you want to increase a drug 10% within this year, that's fine. Just tell us why. Explain it. And I used on the panel yesterday the analogy, and I don't know if you happened to see it, but I was watching TV several weeks ago now, HLN News in the morning, and they had an interesting case of a young boy, about 3 or 4 years old, that had born with a heart defect, had surgery, 3 surgeries, I believe, and they hadn't worked completely, and they were attempting to take him to another healthcare facility to have a new surgical procedure done that might work. They weren't sure, but it was out of network, and the insurance company was not covering the additional charge. And the surgery was 6 to 8 hours, and the additional charge was $1 million. And I think somebody needs to explain to me why you need $1 million for a 6 to 8 hour surgery. So I'm using that as an example on the provider side, but I certainly have the same reaction on the pharmaceutical side. Why do you need the increase? We all saw what happened with insulin. You know, it's a free market. You want to increase your prices. Why? Explain it to the public. Let the public find out why. And I think this is an attempt to begin to bring transparency to the healthcare delivery system, which we do not have, with the exception of the federal government. We know what Medicare and Medicaid rates are. That's about it. So it's an attempt to bring transparency, and that's what the other states that have addressed this issue and are addressing it now are attempting to do with us. I don't know if that answers your question completely, but.
And the transparency, you believe, will then permit the consumer to have a lower drug price?
I believe it will.
That's right. Okay, thank you.
Representative Caput.
Well, Mr. Chairman, just a comment for committee consideration in the audience as well. And you mentioned my involvement with PBMs, and most people know my business is insurance, and now I'm, for the last 15 or so years, majoring in health insurance, group health insurance with large groups. And PBMs come into the equation all the time. And I have never understood the claim that PBMs make, and they make it on the video, that we're here to save you money. The example of a $100 list price of the drug, and then the PBM receives $50. so the drug manufacturer receives $50 instead of $100, is beyond my comprehension how that reduces the cost of drugs. It does not reduce the cost of drugs, it increases the cost of drugs. So the question then is, where are these rebates going and how much are those rebates and what is it really costing the consumer, which we don't know. And the rebates continue on. If you look at some of the large PBMs in the United States and their annual statements, and they're for public record, you're looking at hundreds of billions of dollars of billing that are going through these PBMs, and billions of dollars of profit that go to the bottom line of the PBMs. The PBMs were originally started to just be record keeper. They would charge a cost for just keeping track of the prescription drug from the pharmacist to the insurance company, and they were just a paper facilitator. They would charge $4, $6, $8, $10 per prescription. Now it ain't that way. Not only are the rebates involved, but there's spread pricing where the PBM will pay the pharmacist, let's just say $10, and charge the insurance company $30. That's a spread price. That goes on all the time, and that's hidden as well. This bill does not use spread pricing. And there's other ways that now, the term used to be rebates. Now what you'll find with PBMs is they are changing the terminology. The process is the same. The rebate is going on, but they're calling it something else so that they can try to not have to disclose the information. So I would want to be sure that this bill particularly digs in that they cannot change the definition of a rebate and call it something else and not have to disclose it, because that's the game they're already playing. So the point is, it's time for the people of our state and our nation, and the federal government is finally recognizing it, although as we know they move a little bit like molasses, but they're recognizing that this is an insidious part of driving health care in the United States, and we all pay for it. And so this is a great start, and I commend you, Mr. Chairman, for bringing this forward, and hopefully the committee will support a bill like this at the end of the day whenever it gets done.
Representative Casper and committee members, I somewhat had similar reactions. I read through the definitions, and I can't remember if I called or you went up to see Jennifer and said, hey, Jen, we're not identifying this one or this one, this one. She said, no, that's not, we don't need to. They're included. So they can change the name, but if it's the same process or outcome or approach with a different name, it's included, even though we don't say, and all other alternatives. The way our language works, Jen, if I'm correct, and you might comment on
Mr. Chairman, committee members, I did just look at the definition of rebate, and I understand Representative Casper's concern because it's a term of art used in the industry, and they may use a different term to try to get around it. But if you look at the definition of rebate on page 2, lines 8 through 10, I think it's pretty broad. If we've missed something there, we could revise it. Rebate means any discount, financial incentive, or concession that affects the price of a drug to a pharmacy benefit manager or health insurer for a drug manufactured by the pharmaceutical manufacturer.
Mr. Chairman, Jennifer, my only comment would be the words that affects the price of a drug. And here's why I'm concerned. The PBMs will claim that we're reducing the price, or we're not affecting the price, we're saving the consumer money. So I'm worried about the wiggle room that they might have there. And so it's just having dealt with them for years and not being able to get the information that I'd like as a consultant for employers, but knowing what goes on behind the scenes, that I just want to be sure that it's as iron tight as possible.
Committee members, it's important to know that the committee is not going to be asked to take any action on this piece of legislation today. But we will have presentations following our discussion and on the bill at this point. We can have more afterwards. But we have representatives here that from the various industries that want to comment. And we're going to invite them to do that today. Plus, we have not talked to any of the folks that we're assigning this legislation to, whether it's the Board of Pharmacy or whoever, about what kind of fiscal note do we need on this thing. Because I'm a firm believer, if you want to bring forth an idea, and if it's going to cost money, have the guts to put it in the bill and be upfront about it. So, Senator Madden.
Thank you, Mr. Chairman. I'm hoping we could also have something in the bill that actually creates some evidence or creates some outcome for the consumer. I'm a little afraid that transparency isn't really enough. And I just encourage us to think about that, if there is some way to make sure that that's addressed. Thank you.
Representative.
Yes, thank you, Mr. Chairman. One thing I noticed is that we're trying to do prescription drug costs, but the bill doesn't actually define prescription drugs. It defines drugs. And so I think at least part of this bill, for instance, would apply to acetaminophen down at Walmart. And I don't know that we really need to go there with over-the-counters and so on. I think that we would be better off really defining what a prescription drug is and restricting ourselves there.
Senator Lee.
Mr. Chairman, just this past week on the news at home, there was a piece about a 4-month-old in our area that has health issues which will require a $2 million drug. And the insurer has now agreed to participate in the cost, although it's not yet revealed how much of that will be. But the point is, any person in this room would want to do what they could, make sure that, especially but any family member is going to have a chance at a good life. But that's, and I get the R&D part. I mean, that's not it. But I think if you really want to stir the pot, we can talk about all the claims databases. And for the benefit of people who may not know what that is, there's a very short definition. All payer claims databases are large state databases that include medical claims, pharmacy claims, dental claims, eligibility and provider files collected from private and public payers. They are reported directly by insurers to states, usually as part of the state. So that's a very controversial item, as you well know. Some states require and have all claims databases. We have resisted this all along in North Dakota. And I'm not saying it's part of the answer, but it may need to be part of the discussion.
Senator Lee, I couldn't agree more with you. I can give you several examples on the provider side that what's the justification for this. Other than, as we said yesterday on the panel, you can do it. My running mate, whom you're all familiar with, on flight from Minneapolis to Chicago, his eye goes crazy. He lands, calls his ophthalmologist here. Ophthalmologist refers him to his down there. 2-hour surgery, $200,000. And Blue Cross Blue Shield paid it because it was emergent care. What is acceptable of a $200,000 2-hour surgery in anyone's mind? So we may go in that direction. We've kind of isolated this issue as a separate issue, but it certainly is a legitimate concern. Senator Devlin.
Well, Mr. Chairman, it seems to me that the costs associated with this process in pharmacies are related to complexity and secrecy. So I very much like this bill, but I'm concerned about the implications of it. And I told my son the other day, I said, if it was this easy, it seems to me that Congress would have done this a long time ago.
Congress does nothing.
Well, his response was, Dad, you give Congress too much credit. So one of my concerns with this is the small population of North Dakota doesn't make us a big player. They can just decide not to do business here. And then if this is patterned after a law in Texas, and if there are other laws addressing the same issue in other states, I'd be interested in knowing how recently those laws were passed and what implications have come about as a result of those. And then I guess a couple other things, the Class B misdemeanor, they'd laugh at that. I think maybe some significant civil penalty might be more appropriate. And then I have concerns also about the board of pharmacy. It's my understanding, as with other boards, that their staff and their expenses are covered out of the dues of the members, not from any appropriation from the state. So I'm not sure that it's appropriate that they become responsible for regulating this. And I know that they do the PDMP, but I think that's probably not nearly as complicated as this.
I agree. It would have to be a subset and an appropriation if they were to do it. No question. Further points. Representative Cassidy.
Thank you, Mr. Chairman. Just to comment about PBMs that Senator Dever said might not want to come to North Dakota. I think that'd be great because there are what's called transparent PBMs out there who are becoming more and more prevalent across the country. And any insurance company in North Dakota could use them right now if they so chose, where they do not hide anything. They're totally transparent. They provide a documentation on everything. They share 100% of the rebates with their employer that they're contracted with. And they operate at a fee-for-service just like PBMs when they started originally. So there's alternatives if they would say we're not going to come to North Dakota, which I think would be good alternatives.
Senator Dever also raised a great point, and that is how new is this legislation, what's been around for a while, and what's happening as a result of it in those states. We made an attempt to have some information provided today on that. Most states, I think Texas passed this legislation within the last 3 months or so. I'm not sure what their date of passage was, but it was recent. Senator.
Mr. Chair and Senator Dever, from my understanding, it has been passed but not implemented, or it's just in the baby steps of implementation. So I'm not sure we have data yet on if there were any, they tweaked those two where they have the technical expertise and they have more of the authority to do some of the things.
Further discussion? Seeing none, we'll ask those folks, and we have, I think, quite a few people who have volunteered to comment on the piece of legislation and possibly even propose amendments at this time. I don't know if you've established an order, but I assume you haven't. But if anyone would like to testify on this bill, please come to the podium and do so at this time. You always stand out, Commissioner.
Well, everybody was rushing up to the podium, so I figured I'd meet them up here. Thank you, Mr. Chairman, members of the committee. For the record, John Godfrey, North Dakota Insurance Commissioner. Just a few comments I'd want to make. I think we're very supportive of the overall concept and the direction. I take Senator Rohr's comments very, very well. I think that is not something we're afraid of in terms of helping administer the data collection and the administration of the website. And so we've got tools that we can do that to or add on to it. Where we lack is that expertise in the analysis and looking at what it is. I mean, I think we could present reports and say, here's a graph of what's happened. I can't explain why. And that's not an area we've got some expertise in, and we rely on the Board of Pharmacy to assist us in that, certainly. And so it's the way the bill's written right now. I mean, there's a partnership there already. It's a little splitting hairs on who does what. We're fine going either way. On the comments about what does this do for the consumer, I'll just talk a little bit about some of our experience with going on in the cross country. There is a big push right now to have the insurance departments be the overarching regulator of these PBMs. There's model laws that exist in other states that are being building their way through other associations. I personally have some concerns about that. I think we don't, again, going back to the expertise area of this, we don't have pharmacists on staff. We don't have the technical expertise to review some of these complex negotiations or organizations or structures of what a PBM does and how it works within the marketplace. And so this bill doesn't necessarily create that, but it's certainly a step in that direction, right? And so I just wanted to be on the record and say that we've got some, if we continue down this road and ultimately get to where there's significant oversight by the insurance department, there'll be a significant addition of authority there that doesn't previously exist, including perhaps another division that would look at this. My colleagues down in Arkansas and Kentucky have gone the route of the kind of the broader administration and regulation, and have been met with. I asked them, I said, well, do you have a pharmacist on staff? Who's your enforcement? What do you have? And they said, well, what do you mean? It's like, well, you're going to have to understand these formularies, you're going to have to understand this process a little bit. And their answer is back, well, we've got our investigators that go, they use drugs.com and use some of the stuff. And that's a little concerning to me, and wouldn't necessarily produce the results I think we're looking for. But what this bill does do is I think it gives you all and consumers the data we need to then take that next step, to see where that next step makes sense. And so I'm not sure there's, this is a transparency bill, and there will be some benefits that come out of that. I see the benefits that come out of it as when you've got the information, what's that next step then? What does that mean for, where does regulation go? Where are the issues that we can actually pull on as a state with our state levers to actually cause some effect on this? Those are kind of, again, the overarching comments. I'm not a pharmacist. I certainly don't have the expertise in PBMs. We know they're an issue. We know there's added costs that's coming with them, and we're happy to help and assist where we can. And if that means we're the data warehouse and the administrator of the website and kind of being the flow between, we're happy to do that. We would be relying on the Board of Pharmacy to be our analytical side of it, so we don't have to contract on, because that wouldn't seem to make a lot of sense. We've got the experts in the state that can do that. As long as they're willing to partner, we are too, and we're excited to see this legislation. One other comment, and I'll bring a map down after lunch that kind of addresses what other states are doing currently. It's hot and presses. I got it yesterday in my email box, so I'll print it out just so you can see where other states are looking at how they're addressing it. This Texas law, we reached out to Texas. Again, it hasn't been implemented yet, and so they don't have any data, obviously, but they've been supportive, obviously, of working through this. So we've got some colleagues on in Texas that would be happy to help us too as we get going, but I'll stand for any questions, not that I have any expertise in this area necessarily, but we're happy to work with the committee and with the Board of Pharmacy and whomever. So.
Thank you, Commissioner. Any questions? Senator Dover.
Thank you, Mr. Chairman. Mr. Commissioner, if you've looked at other states, are they already creating the database that we would be looking to create with this one? Can we get the information just by looking at theirs?
Mr. Chairman, Senator Dever, I don't think so. I think Texas is the real first look at that database, right? And that would be on Texas claim, right? That would be on Texas information. So I think there is some benefit and some value in pulling this. What I think this does do is having Texas being a very large state leading the way, I think that we'll be able to pull off that data then essentially as well, and so be able to tailor it for North Dakota. And so it won't, by the time I think this gets implemented, I don't think it'll be a reinvention of the wheel for the PBMs, the providers, or the health insurers to do this. And so I think that's the benefit we have of kind of what we had in Texas.
Further questions? Thank you, Commissioner. Is there anyone else?
Chairman and members of the committee, for the record, Mark Hardy, Executive Director of the Board of Pharmacy. Only comment, I just want to echo Commissioner Godfrey's comments as far as us willing to partner in any way we can, and obviously continue to engage in discussions as far as what the solution is and any part that we can play that you all give us as far as authority moving forward with legislation. We certainly are willing to step up and serve that for the public good. So the only kind of nuance I'll throw in as far as the finance of the board, Senator Dever is correct in the fact that we don't receive state appropriations. We're run off the license fees, but we do also regulate the drug supply chain. So the manufacturers, distributors, kind of business categories underneath the drug supply chain is something that we do regulate. So there are some structures there from that standpoint, and then also from overall enforcement. Obviously, we license those entities. We don't license PBMs or we don't license insurance companies. So that would be something from an enforcement standpoint. as far as having a tangible license. And of course, that's something that we can engage in with the Insurance Commissioner's Office and determine how that may look as the committee discussions move forward. But I'm happy to answer any questions. So I just want to make sure I can if you have anything. So.
Thank you, Mark. Any questions? All right, thank you. Representative Nelson, $20. All right, is there anyone else here? Yep, come on up.
Good morning, Mr. Chair and members of the committee. My name is Sarah Orange. I represent AHIP, America's Health Insurance Plans. We're a national trade association representing the health insurance industry and related products. So we're still reviewing the bill. We have some preliminary comments. We wanted to take this opportunity to share those with you today. Pharmaceutical advances have revolutionized the treatment of certain diseases and have saved lives. However, the rising cost of drugs in recent years has strained the budgets of states and local governments, individuals, and families. So there's a need for more transparency around drug pricing. And when we evaluate these drug pricing transparency laws, we've seen a number of them across the country. We kind of look at some different principles. We want to make sure that any measure that is proposed has protections for proprietary and confidential information. We'd like to have pharmaceutical manufacturers placed on similar footing with respect to financial disclosures as other sectors in healthcare are, and provide advance notice of excessive price increases as this bill does. So we see this as a necessary first step for this conversation in North Dakota, and wanted to share some examples of some of the information we've seen is pretty new, but some of the information that we've seen from other states. So in California, they have a bit of a different transparency bill, but they have the advance notice requirement. Health plans in California paid nearly $8.7 billion for prescription drugs in 2017. Specialty drugs accounted for only 1.6% of all prescription drugs, but they accounted for over half, 51.5% of total annual spending on prescription drugs. Generic drugs accounted for about 90% of all prescription drugs dispensed, but only 23.6% of the total annual spending on prescription drugs. Oregon has a report that just came out. They looked at Humira, and Humira topped the list for both the 25 costliest prescriptions and the greatest increase in plan spending. And we submitted some written comments and there's citations, so you can click on the links to those reports that came out if you would like to pull more data or review what has come out. So again, with this kind of information, we think that North Dakota can begin to understand the true impact of prescription drug spending on healthcare affordability in this state. With respect to the bill, I had a couple of quick comments, and we're still collecting feedback, so if there's another opportunity, we'd love to submit some additional thoughts. But we would prefer for the carrier reporting requirements to, health insurer reporting requirements to go to the Division of Insurance. We often work with the Division of Insurance. Our members submit regularly information to them, so we would request that the carrier submissions go to the Division of Insurance. With respect to the proprietary and confidential information, we noticed that on page 4, line 28, under the PBM section, there was a bit of a difference in the text in this bill that is in not in this bill, that's in the Texas bill, that said this report must be published in a manner that does not disclose or tend to disclose proprietary or confidential information of any pharmacy benefit manager. That was a discussion point in Texas, and we would ask that that language be added to this bill to mimic more closely the Texas language. And then earlier we had some discussion around 30-day supply or the manufacturer package drug container. I noticed that wasn't defined, and I was confused about what that meant, so maybe a definition there might be helpful so we can get at some true transparency and know what we're all talking about. So thank you all for the opportunity to comment on this important matter. We think this is a great first step, and I'm happy to take any questions.
Questions, Representative Gaff?
Thank you, Mr. Chairman. Sarah, I've heard for many years proprietary and confidential information that PBMs possess and are worried about. Can you give us some examples of what type of information that entails?
Mr. Chair, Representative, I don't have specific examples. I do have from the concern from the health plan side is similar to what the Federal Trade Commission has cited in the past. We want to make sure that we can
maintain those discounts, that information's not getting out such that we have a disadvantage in receiving additional rebates. I think that is a broader concern about just, let me see here. I was just going to look at what the FTC had said, excuse me. So yeah, it runs the risk of restricting the ability of plans to effectively negotiate savings in contracts with the pharmacies. So I think it's an overall competition concern that we have.
Thank you, Mr. Chairman. So Sarah, what you're talking about is the information we're trying to get.
Yeah.
We're trying to find out what is the rebate, who's getting it, and how much is it, and so on. So to me, it's a contradictory request. Proprietary means I don't want you to know how much rebate I'm getting, but I want to know how much rebate the other people are getting, and I don't want you to know where it's going. So I can't, unless you can come up with some suggested definitions of proprietary that does not impede what we're trying to get to, which is the bottom line of what's going on with rebates, how much are they, and how much is it costing the system. I just don't see any credibility in that type of discussion. But I certainly stand to be corrected. Just give us some definitions.
Mr. Chair, Representative, thank you. I'm sorry, I was not very clear there. So we're supportive of this level, aggregated level of transparency, what's in the bill currently. It's really when what information is then disclosed in the report to the public. So I think that language, we would like to have some additional protections on what is turned around and disclosed. But we agree with what is in this bill in terms of what should be disclosed to the state.
Thank you, Mr. Chairman. So the insurance department can see what the rebates are, but if you want to aggregate it, aggregating to me means how much is the total rebate that PBM company A received for the whole year for this drug. So it does not break down in individual contracts and individual situations. It's the total, which gives you nothing. It's just you're getting a big ball of nothing. So, and if we can't share it with the consumer so that they know what's going on, so that maybe they can get a little irate and talk to their doctors or their pharmacists or their legislator, what good is the information?
Mr. Chair and Representative, yeah, well, the requirements in the bill require aggregated rebate disclosure reporting, and it does require reporting then to the consumer. We're just asking that we consider the proprietary and confidential nature of that. I don't think we want to prevent the Division of Insurance or whatever entity would be collecting this information and then disclosing that to the consumer. It's just an added protection that was in the Texas bill that we would ask be added here.
Representative LaFleur.
Thank you, Mr. Chairman. Sarah, I think it would be helpful if you provided the committee with what they did in Texas and more detail than what you're probably giving right now. Because I believe, and I know certain other people on this committee are concerned to the point that the pricing has gone up so much that, and everybody's asking for carve-outs. To me, this is a carve-out. I'm sorry. So I would ask you to provide the committee with what Texas is doing and why they felt the need for that proprietary and confidential information to be kept within their bill. Thank you.
Mr. Chair, Representative, yes, we have tried to put together what we could in advance of this hearing today. I'm happy to provide additional information and continue the conversation.
Any other questions for Sarah? Thank you very much, Sarah. Is there anyone else? Welcome, Megan.
Good morning, Chairman Kaiser, members of the committee. My name is Megan Hoon. I'm the Director of Government Relations for Blue Cross Blue Shield of North Dakota. We are anxious and are thankful to the committee for providing the bill drafts you did a week ago, and we look forward to gathering our internal stakeholders to review them in depth and provide some good feedback at the next meeting. We were asked to reach out to our colleagues in other states and at other blue plans to see sort of what their response to this has been, and as was indicated in some of the testimony ahead of us, they don't have any concrete data yet because their bill won't go into effect until February of 2020. Now, that being said, I did visit with a few of our friends, and I can share a little bit of information about process and what happened as they were going through the passage of this bill, if that would please the committee.
Sure.
Okay. So in Texas, actually, they thought originally, the bill as it was originally introduced had a 40%. So where your bill says 10% over the 12-month period, theirs was 40%. And so the Health Plan Association, I think it was AARP, several of the independent plans, et cetera, thought that perhaps this was introduced by Big Pharma as sort of a preemptive strike because there really weren't any teeth in the bill. If you have a drug that goes up over 40% in that over the course of a year's time, you're talking about some national media there. That's the EpiPens and the other drugs that we've seen sort of that happen recently. So nobody really thought it would pass, according to our friends in Texas. When the bill went to the floor, a legislator, I think in the House side, amended the amounts, the percentages down to 15%, which is where the current bill stands. And then all of a sudden everybody took notice, right? Everybody who might have been opposing the bill because it didn't have any teeth then turned and took notice because 15% over the course of 12 months or a year is better, right? It provides a little bit more insight into what's happening with that drug in terms of reporting. The reporting is aggregate with the PBMs to the Division of Insurance and to the point of the Commissioner and the Board of Pharmacy. I think that that's something that we can support. We provide data, proprietary information to our regulator all the time and haven't had an issue with that. What I will say with respect to the warehouse issue and cyber issues as we've seen them, there will be a breach at some point. That's happened multiple times in whether it's the finance industry or health insurance or whatever. There are breaches. That is the reality that we are dealing with today. So I would suggest that if you're going to give the department and the board an appropriation to warehouse that information, you also give them an appropriation to fortify their cybersecurity efforts. And I would also suggest that maybe you put in some guardrails for what happens. If you're going to require us to provide information into a database, at what point do we no longer become responsible for that information or providing financial remediation to those folks who are hacked, right? But back to the Texas legislation, everybody sort of flopped and started supporting the Texas legislation once the percentages were lowered. The 15% in 12 months is great. I think we are supportive of, I can tentatively say I think we will be supportive of the 10% that you've put in. That's better. The only thing I would also echo with Senator Roars is, and I think Representative Casper said the same, that the look back in reporting, I think as opposed to a February date, perhaps an April or a June date might be advantageous. Our friends in Texas said some of the same thing. I would assume the folks from the PBMs would have more input into that because it's really their reporting to do there. There are 30 states that have introduced strict transparency pricing legislation. It is passed in a handful. I think Texas and California are getting the most notoriety here because they're the most stringent. Texas passed before California. As I said, they aren't implemented yet. California is going to be implemented, and AHIP will, I think, provide more data on that as they get it, but there's just very limited data at this point. I think that's all we have at this point.
Any questions for me? Megan, one thing I can tell you is the position member of the Texas legislature that's a friend of mine who was a sponsor said, boy, you wish you would have put it in at 10. Big mistake going at 15, but. All right.
Okay, thank you.
All right, is there anyone else here?
Good morning, Mr. Chair and committee members. My name is Zachary Poss, and I'm Senior Manager of State Advocacy at Pharmaceutical Research and Manufacturers of America, where the trade association represents the brand manufacturers of innovative drugs. And I'd like to thank you for the opportunity to comment on this bill today. Discussions about the costs and affordability of legislation of medicines are very important. But legislation like this will not reduce patients' out-of-pocket costs at the pharmacy counter. As was mentioned, pharmaceutical manufacturers pay significant discounts and rebates, which should reduce prescription drug costs. Because of these rebates, PBMs like CVS Health stated that its drug spending growth was kept to only 1.9% in 2017, which is down from 3.25% in 2016, 5% in 2015, and 11.8% in 2014. Additionally, another large PBM, Express Scripts, announced that their prescription spending only grew 0.4% in their commercial plans and projects similarly low growth over the next 3 years. However, pharma is increasingly concerned that these substantial rebates and discounts paid by the manufacturers, approximately $166 billion in 2018, do not make their way to offsetting patient costs at the pharmacy counter. We believe that patients should receive the benefit of the rebates at the pharmacy counter, enabling patients to better access and adhere to their medicines. Additionally, while we believe transparency across the entire healthcare spectrum is important, we think that transparency should be meaningful and better help patients understand their costs. For example, we believe that it is important for patients to understand whether their prescription is covered under their health plan, what tier of the formulary the prescription is on, and what level of copay or coinsurance they'd be required to pay at the pharmacy. You've heard a great deal of information today, and I'm sure you'll hear more as well. But I want you to know that we're a resource to each of you and look forward to working with the committee on this complex issue. Patients are not seeing the savings that are being paid by pharmaceutical manufacturers to PBMs, insurers, others in the supply chain. And it's time that we need to figure out how patients can benefit from these significant discounts and savings at the pharmacy counter. Thank you. I'd be happy to take any questions.
Senator Mather.
Thank you, Mr. Chairman and Sarah. I had similar concerns about the consumer, and I'm just wondering, do you have a suggestion so that this process actually ends where the consumer has a reduced drug price?
Mr. Chairman, Senator, there has been legislation introduced recently in New Hampshire which provides a mechanism for pharmacy benefit managers to apply a portion of the rebate at the point of sale to reduce patients' costs directly when they go and pick up their medicines.
Thank you.
Did that need legislation?
Yes, it was introduced.
Why?
Excuse me?
Why? Explain why that would require legislation. That the PBM couldn't do that right now.
Mr. Chairman, some PBMs opt to voluntarily do that, but there's no requirement on a PBM to do that.
Representative Casper.
Thank you, Mr. Chairman. Zach, just a clarification, you said 166 billion in rebates. Was that in calendar year 2016?
Mr. Chairman, Representative Casper, that was 2018.
2018, okay. And then do you happen to know what the total prescription drug costs nationwide for prescription drugs were in 2016, 17, or 18, the most recent year you might have for
Mr. Chairman, I do not know off the top of my head, but I can get that.
Did you find that out?
Yeah.
And then last question as far as the rebates, 166 million of rebates paid by the manufacturer to the PBMs, correct?
Mr. Chairman, 166 billion.
Billion, yeah. So if the drug manufacturers had not had to pay the rebates, could they not have reduced their price of their drugs by 166 billion?
Mr. Chairman, I can't speak for any individual company's business practice, but I'd say it could be a possibility.
Senator Lee.
Mr. Chairman, I'm not nearly as impressed with the fact that especially the two biggest PBMs, they have had a modest rate of increase, because the bigger deal is it's the smooth duck on top of the water, but the feet really paddling underneath. Who's getting ripped off? I mean, really tasteful when I choose that phrase. In the squeeze that's going on in order to accomplish that, in a large part, in my opinion, pharmacists are among those that are really taking the hit. Because there's a place where you pay to play, so to speak. And I'm sort of asking if you have any, because I don't think we disagree entirely, you're just telling us those adult kids are not having a big increase in drugs. No, but they're not paying pharmacists the kind of service fee that they have had in the past, and they are more and more an important part of our health delivery team, because they are much more accessible most patients than the healthcare providers themselves. So I'm not interested in cutting, in giving somebody great credit because they've been able to keep as a PBM the drug prices here. If down here they're shortchanging terribly, one of the professions that is a really integral part, more and more so of the healthcare delivery.
Mr. Chairman, Senator, I can't speak directly to the interactions between a PBM and a pharmacist, but I can say that we as a trade association are aware of a lot of community pharmacy associations and generally pharmacy associations in a lot of states really trying to discuss this issue more broadly, introduce legislation to address what they see as some of these issues.
We hear a lot about it.
Representative.
Thank you, Mr. Chairman, Zach and committee and those in the audience. My seatmate, Representative Meyer, is very good at data. She just pulled up the drug spend for the United States in 2018 for the prescription drugs. It was $344 billion. You indicated that the rebates were $166 billion. That's almost 50% of the cost of prescription drugs were not because of the cost of the drug, it was because rebates were paid. So you could theoretically state then that if rebates were eliminated, the prescription drug cost to the people of our nation would go down by about 50%. That's theoretical supposition, which I think has some merit.
Representative Goldberg.
Thank you, Chairman. So there's been a lot of, so we talked about the tier 1 drugs, the different tiers, we talked about the formularies, we talked about the rebates. Do you have any ideas for helping folks save money, or not even just save money, pay a reasonable rate for pharmaceuticals that aren't on the formulary or there isn't a rebate available? There are those medications that are out there that people need. And as someone who recently got a quote on a drug that was over a quarter of what my income per month is, I'm just curious what ideas do you have for those folks that are dealing with those non-formulary type drugs?
Mr. Chair, Representative Dobrovich, I can't really say what a health plan chooses to include on their formulary and how they make those decisions on what to include versus what to exclude from their formulary. But speaking to some of the out-of-pocket issues, especially for drugs that don't have rebates, there's legislation and also done through the Insurance Administrator's Office and the regulation in Colorado, where at least a quarter of plans have to offer an option to their enrollees where the out-of-pocket cost for their prescription drugs is capped at 1/12 of their annual out-of-pocket costs to better help patients afford on a month-to-month basis their drugs.
Thank you. That's what I was looking for. Is anybody doing anything out there? Thanks.
And I can provide that.
I would love it if you could give me more information.
Mr. Chairman, I'd be curious to know who pays for all the advertising for drugs. There was a time when there was drug companies didn't advertise. They didn't spend any money on that. You went to the doctor and the doctor said, I think you should have this. But now the patient goes to the doctor because they saw that although this drug will probably kill me or do something dastardly to me, and there's 1 in 100 chances that I can be helped by it. And so they run to the doctor because they want that drug. So should we add some lines into this bill to find out who are the pushers? Is it the PBMs that are pushers, or is it the local pharmacy that's paying for that advertising? or is it the big pharmaceutical companies that are paying for that advertising? Because I'll bet if we didn't have to see advertising on that took up a lot of time on TV, enough time so you could go get that extra cup of coffee, we'd probably see lower drug prices and less of them being pushed and sold. What do you think?
Mr. Chairman, I can't speak to any individual company's business practices, but what I can say is that the brand manufacturers spend significantly more on research and development than on direct-to-consumer advertising.
Further questions? Senator Representative.
$20 and I'm a senator. Zachary, you have a number for the amount manufacturers spend in rebates, but another way that's becoming very popular now is this, you don't have to pay, it's always very expensive drugs, but you don't have to pay anything. We'll take care of you for 6 months or a year, or we'll give you coupons and so on, so there's no copay for the customer. Do you have a number for how much companies are spending on that?
Mr. Chairman, Representative Nelson, I do not have the number of copay assistance, the total value of copay assistance programs off the top of my head, but I can definitely get that for you.
I would appreciate that if we could. And then if I could, in this entire non-transparent, scheme of pharmacies, it was everybody's telling you that they're saving you money. But it was so common across the country that people had to pay more when they co-paid with their insurance than if they just walked in and paid cash. A practice that the pharmacist was forbidden to tell the customers through contracts and trade secrets, that they had to pass a federal law saying the pharmacist has the right to tell you. But nothing requires the practice that I know of that the pharmacist would go to the lowest price. Do you know, have any numbers for what that's costing consumers where they're being charged so much through this insurance thing? Because insurance doesn't print money. I mean, how much more are we paying for drugs because we funnel it through this insurance side of things?
Mr. Chair, Representative Nelson, I don't have a number for that gap that you're mentioning, but I do know that some states are taking action to ensure that when a patient goes to the pharmacy counter, they would not pay more in a copay than they would if they were not paying through their insurance benefit.
Okay, well, thank you.
Further questions? Thank you very much. Is there anyone else here to testify on these proposals?
Chairman Kaiser, members of the Interim Healthcare Committee, Josh Aspig with ARP, thanks for your patience and letting me get that out. I just got home late last night, so didn't have a chance to get the packets put together to make that easier. But appreciate you guys digging into an issue that, if you haven't seen or heard, is very critical and a very passionate issue for our members here in North Dakota. And before I get into that, most of you know me, but for the few who don't, AARP is a nonprofit, nonpartisan membership organization of over 88,000 individuals aged 50 and older in North Dakota. And we work every day about trying to make real possibilities continue to expand as you age in North Dakota. And our story dates back to when our founder found a former colleague of hers 60 years ago living in a chicken coop because her health care costs and retirement benefits weren't able to sustain her in doing that. And it's from that we found in our fight to help folks live safe, independent, healthy lives. And we really work in three primary areas: helping people choose where they live, helping them remain financially secure, and access to affordable health care. As I mentioned at the outset, the rising costs of prescription drugs hits our members and frankly all North Dakotans in all three of those areas, and it's a very high priority for us. I would tell you a little bit off script. We started a number of years ago doing coffee and conversation meetings. In addition to some of the education work we do around the state in some of the larger communities, we've been going out to some smaller communities and visiting with folks about what's on their mind, what are they hearing, what are they seeing. In the last 3 years, we've done approximately 25 of those meetings. At every single one of them, unprompted, the first issue that comes up, prescription drug prices. Unprompted, first issue that comes up, the rising cost of prescription drug prices. The second thing, if you didn't see, getting back to my testimony, is we've been working at this not only at the state level, but the federal level as well. They are taking some steps, albeit not as quickly as we'd like to see, but hopefully they'll keep moving in the right direction. The reason we're working on this, besides what I've just told you, we know that voters, AARP's 2018 voter issue survey, 92% of voters age 50 and older told us that candidates' positions on lowering prescription drug costs was important. 74% said very important. Some quick facts, I think, as you dig into this and why increasing drug prices hit older North Dakotans particularly hard. Most Medicare beneficiaries live on relatively modest incomes. For example, a Kaiser Foundation study from 2016 shows the median income for Medicare recipients is just over $26,000, and a quarter of the people hover closer to $15,000 a year. They also have very little saved up in savings. Half the Medicare population has less than $75,000 saved up, and so their ability to absorb increasing expensive prescription drugs that they grow more reliant on as they age, by the way. The average, as you see on one of the handouts, average older American takes 4.5 prescription drugs typically on a chronic basis for that. But one of the most staggering statistics, I think, is on this handout that you see. It's the blue and pink one. As part of it, it says how North Dakota residents are impacted by high RX costs. If you go to the bottom bar where it has the pill bottle, it says RX 28%. In 2016, 28% of Americans stopped taking medication as prescribed due to cost. That's more than 1 in 4 stopped taking their medications as prescribed due to cost. And so it's clearly an issue. As you see on that same handout, you can see specific to disease groups. Over 60,000 North Dakota residents have been diagnosed with cancer, close to that many with diabetes, and then just over 22,000 with heart disease. And what's happened on the brand name drug increases over a 5-year period from 2012 to 2017, about what's happened with price hikes of those. As you can see, one nearly doubled and another jumped over $100,000. If you look then, turning back to the second fact sheet, this is my favorite one because I think it speaks really to a number of questions that are brought up. I'll start you in the middle, and it says in our state, the average annual cost of prescription drug treatment in North Dakota increased 57.8% between that same 2012 to 2017 time frame. At the same time frame, the annual incomes of North Dakotans only increased about almost 7%, 6.7%. I'm not a mathematician, but it doesn't take long to figure out, knowing that many of them are on fixed incomes or severely limited incomes, that is going to cross paths pretty soon. And in fact, as we've gone around the state and heard stories, we've heard stories from my friend like Pat, who lives and is working here. She had a prescription drug that cost her $60 and 10 years ago. Today she pays $600 for that drug. More egregious to me is my friend Roger, who I've met recently and gotten to know, and got to know him and his wife Vicki. He was diagnosed with leukemia right the day before he retired. Thankfully, he had North Dakota PERS and was paying $10 for his copay. when he was switched over to Medicare, because Medicare in part can't negotiate prescription drug prices, which you all can't do anything about here, but is another issue. His copay or his cost, out-of-pocket cost, jumped to $2,400 a month. By the way, the full cost of that drug, if he would have had to pay the full cost of that drug in the United States, was $9,600. Luckily, he found it for $900 in Canada and is able to get it from a Canadian pharmacy that allows him to live, because without it, it's 3 months to 3 years to do it. And so clearly, this is an issue that something and steps need to be done about, and we know that states can't solve the problem alone, but thinking and knowing this committee's willingness to dig into this, we think is an important first step. And before I'm going to jump off script 1 second again, a lot has been said today about what happens within the process. And I want to thank the chairman and Jennifer for the video up front, because I think the video does help sort of explain the process. But in case you missed it, the consumer pays off of the list price. The video was very clear about that. The consumer pays off of the list price. And so transparency is important, and understanding what happens certainly helps. But you really got to go back to and get to the root of the process, which is the list price. And we're hopeful that in addition to this measure, you might take a look at some other ideas about looking at how to help curb prescription drug costs as well. A couple of things about this bill. We think it's a good first step. We certainly think it's moving in the right direction. We appreciate the bill draft addressing all 3 levels, the PBMs, the insurance companies, the manufacturers as part of it. A couple of suggestions. The first one has been mentioned, but I think it bears repeating. That discussion about $70 or more for whether it's a 1 pill, 1 month supply, 1 year supply, and I understand the manufacturer. I think a clear definition of what that means would really help us, and I think others you've heard get a better feel about what that means for the $70, the 10%, the 40% increase. The second is, and maybe this is already being worked out based on previous comments, is we just wonder if the Board of Pharmacy is the right place to put that. And so don't necessarily have a better suggestion at this point in time, but it's certainly something, independent review, or I don't know that we'd have a problem with the insurance company, but that was one question that popped in our head as we reviewed it. Again, we appreciate the momentum. In case you're unaware, this issue has probably, at least in our world at ARP around healthcare, has received more attention in the last 16 to 18 months. There have been over 30 bills addressing prescription drug costs passed in state legislatures that we have worked on specifically. There have been many more than that introduced around this issue and to look at. And so I think states can make a huge impact. It's relevant not only to thousands of North Dakotans fighting the disease, but those paying for health care coverage and to the state. And so we want to, again, thank you for your work on this issue. We appreciate the effort to make medicine more affordable, and this bill is certainly a step in the right direction. We look forward to working with you on it.
Thank you, Josh. Any questions from the committee? All right, thank you very much. Is there anyone else here to testify? Brad, welcome.
Yeah, thank you. Dr. Bradley King. I'm a dentist in Bismarck. I'm also, along with being a healthcare provider, I'm an employer too, and I'd like to address Senator Matter's concerns. One of the things that I have, in over 25 years of, giving employees benefits, I have never been asked by an a medical insurance company is, what pharmacy benefits manager do you want to use? We've had no choice in the matter. It's always Blue Cross Blue Shield picks it or Sanford picks it. If we had some kind of choice in the matter and the information supplied to us so we could make that choice, if that would be a required part of taking out our new policies each year, that would be a good thing. If somebody would provide us and say, okay, you have there's not that many pharmacy benefit managers out there. There's maybe 7, 8 major companies. And if we had the choice of, okay, this one charges a flat $4 per prescription to manage your benefits for your employees. Easy choice, versus this one gets rebates and, and they charge this much and it varies depending on how much of a rebate they get as far as how much your employees are gonna pay. So if the insurance companies, Blue Cross Blue Shield, Sanford, we don't have that many in the state that we need to deal with, could make it, if it could be made some kind of requirement that we do get a choice of pharmacy benefit managers, I think that would be helpful. And again, with Senator Dever, I would agree that Class B misdemeanor is kind of a minor threat. They just tie it up in courts. It'd be a whole lot cheaper just sitting on it and running it through attorneys than it would be to have to deal with that.
Thank you very much, Matt. Any questions? All right, is there anyone else? Matt?
Thank you, Mr. Chair, members of the committee. For the record, my name is Matt Schaefer with Medica. I've got good news. My remarks will be short. Most of what I was going to say was covered by previous testifiers, so it's always nice to not go first. But one piece that Senator Matherton asked a question about how additional transparency is used, and that's something I want to talk to, because normally I don't like to talk about Minnesota when I come over here, but in light of the Gophers game, I think I'm safe this week. Basically what your bill's asking for is more information. So you as policymakers can make better informed decisions on what bills you're going to pass in 2023 and 2025, assuming if this passed in 2021. Now for over Minnesota through Twin Cities, we do have a couple of avenues where we have additional provider transparency information where we can make decisions. So there are a couple, so I'll talk to you a little bit about one private market solution example is about 15 years ago, we recognized that if an individual wanted to go out and get a colonoscopy, and you were getting heavily recruited to do so if you were turning 50, you could go and do that for about $2,700 at an inpatient facility, inpatient hospital. But if you did that in an outpatient facility, same doctor, it was going to be about $700. And because of the Minnesota community measurement data, as well as other data that payers had the latitude to make public, we were able to put that information out there. And you saw a big shift from inpatient to outpatient, and you saw those hospital systems start building up more outpatient services where they were charging a very similar price. So that was a silver bead. That's a small example where prices went down, but that was a result of additional transparency. The other example I want to give you, and this is where as a payer we were able to make a better informed decision because we had more information to work with thanks to additional information. We were able to identify that in one cross-section of the state, we had one provider group where they were providing far more spinal surgeries than one, what evidence told us was necessary, and two, what anybody else up the street was doing. And so basically we were able to approach that provider, have a conversation with them, and say, look, here's your utilization, here's everyone else's. And in order to meet them halfway as a payer, we expanded our PT network, we expanded our chiropractic network, and we really worked with the provider to get more people referred to other interventions for back pain. So we didn't have everyone going in for a surgery, which frankly was more expensive and obviously had a recovery. So these are decisions we were able to make because we had more information. So if you go forward with this bill, I can't tell you what's going to be done with a transparency law in North Dakota, but what I can tell you is when you've got details in front of you that aren't from Medica or they're not from another interest group, but it's actually your data, that's going to allow you to look at it and see if there are policy interventions you can make. I'm happy to answer any questions.
Questions for Matt? Matt, I would only say a couple of things. This committee will be looking at the RAND study and some other things on the provider side in a future meeting. So it's not that we're not going to have those discussions and consider potential legislation. But one of the things I've learned is you can't put too many things in the basket or you'll lose it all. And this bill is going to go on its own, and we'll get into a provider bill if appropriate if the committee decides to go there. But I certainly agree with everything you've said. And committee members will try and get the RAND study out to you if you haven't read it. It doesn't have North Dakota data in it, unfortunately, but it does compare the provider costs in various states. And And it's really extremely interesting. It seems the larger the network, the higher the price, is one of the general findings. There are exceptions to that. And the variability within a single network and between networks is truly amazing. So we'll get that information out to people, and that will be the focus of a future meeting. All right, any other questions?
And Matt, you forgot there is a jackrabbit up here.
Oh.
I'm also a gopher though, so.
All right. Because I thought you went to Bull Center. I must have been
How many schools did we go to?
Well, 2 schools, 3 times.
All right, is there anyone else here to comment on this segment? And while it's coming up, committee members, as you can see, Jennifer and I have once again engaged and estimated the time required for different sessions today. So after we get done with this one, obviously we're going to break for lunch and come back. Mark, I assume you can stay and be here this afternoon.
Good morning, Chairman. My name is Danny Weiss. I'm Senior Executive Director of Pharmacy with Sanford Health Plan. I wanted to keep my comments brief today because, similar to others, we've not had a time to fully vet this legislation. So I wanted to give some initial thoughts and some things to share with you today for thought for future evolution. We're excited for the opportunity to continue this dialogue and participate actively in this. First and foremost, we do believe in transparency, and we do support this measure in general and the concepts that you're attempting to accomplish here. But I wanted to call out one thing that I think this Texas legislation really missed the mark on. In the pharmaceutical distribution chain, there are 3 wholesalers that control 92% of the market in the United States, 3 large companies. In 2008, one of those companies had a $350 million settlement because they conspired with another company to artificially inflate average wholesale price, which is the reimbursement model for most insurance payers. They inflated it by 5% over a 2-year run. So when this came to light, drug prices dropped by 4% overnight. And if you do the math, if you raise something 5%, you have to reduce it by 4%. It's equal numbers. So it wasn't as if they kept a 1% margin in there. But the point being that wholesalers are an integral part of the distribution system. And I do not believe, and I would raise the question, is this a glaring oversight from the transparency piece? Because if you do research on wholesalers, they're reimbursed on a percentage of margin. So a wholesaler enjoys selling high-cost drugs because they get a percentage of that. So $100 insulin is not as favorable to a wholesaler as $400 insulin. So we have, when we saw that video earlier, we saw perverse incentives. This is a classic case in point of a perverse incentive that a industry and a very controlled segment is within their reason doing things that I would question and I would push back on as far as needing more transparency for the entire system. And as I raise that question to the group, part of our concern as a payer is the balance of being a fiscal steward of our premium dollars. As you rightfully said, we don't get to print money. We need to be stewards of the premiums we collect. We also have to balance that with being responsible payers and pay our providers in a reasonable way. And this type of transparency on the wholesaler end may help us to alleviate some of the concerns from the pharmacy industry and from the pharmacists who are under pressure with the current reimbursement model. So I raise that as a question and something of exploration, because to the way I read it, I do not believe that the bill will capture the end consumer benefits that your goals are. And I'm afraid that there will be a big pocket opened to collect anything that rolls downhill. And unfortunately, it'll end up in the pocket of one of the 92% ownership of the wholesaler agreements.
Very good. Any questions? Representative Castle.
Thank you, Mr. Chairman. Jamie, are the rebates paid by the manufacturer to the PBM or by the wholesalers to the PBM? Do you know? or both?
Mr. Chairman, rebates are paid from manufacturer to through the PBM, and those get distributed to the insurance from my end of the payer schematic and what my knowledge base is in that space. There are additional incentives and discounts that wholesalers pass to pharmacies, and those are also considered rebates by definition.
So there's a rebate scenario from the wholesaler to the PBM as well as the manufacturer to the PBM, or am I misunderstanding this?
I believe we're not clear on that point, sir. There are rebates that go from the manufacturer through the PBM to the insurance or the end payer that exists. There are additional incentives from wholesalers to pharmacies through discounts and other rebates that occur in that supply chain. And from my knowledge, they originate either from the manufacturer or from the wholesaler. And I'm not aware, because I'm not in that end of the distribution system. I know they exist, but I do not have the ability I don't have the ability to dig into that aspect that isn't relevant to my area of expertise as an insurance.
And the wholesalers are setting the price of drugs. That's why they're the middleman that's not being worked in to the PBMs or to the system.
Mr. Chairman, the prices are actually set by two different publishing companies. One of them is Metaspan, the other is First Data Bank. And in this 2008 occurrence, they conspired with one of those companies, First Data Bank, to publish that information and to artificially inflate it. That was the allegation, and they settled without ever admitting that they had done that. So the wholesaler does not technically set the price. It is set by a third party, adding even more confusion to a complicated process.
Further questions today? Thank you very much. Did you want to comment on that other issue or on the Medicaid expansion?
Only if you wish, sir.
Okay. Good. Because the committee saw that information and you might update them on what you found on that.
I'd be happy to, sir. Mr. Chairman and members of the committee, during a preparation meeting, and some were present, some were not, there was a issue that was brought forth at the beginning of that meeting some 2 or 3 weeks ago, and there is a reimbursement that Dr. Joyce located and identified. We've isolated the issue there with that Medicaid expansion claim. It was a setup error by our PBM. They were basically paying themselves as a brand name medication for a generic. And that explains why the egregious margin was, because they had it classified incorrectly and set up incorrectly. So they were reimbursing themselves as a brand instead of a generic. We have taken steps to both audit our full claims experience and identify any other cases similar and reverse those claims as well, so that we are not held harmed by that setup error and will not be passing that expenditure on to any of our premium payers, which include the state of North Dakota, as well as other private payers, or private premium payers.
And then the audit will be done for Medicaid expansion and for the PERS program, correct?
Yes, sir.
Mr. Chairman.
Senator Madden.
Mr. Chairman and members of the committee, sir, it's interesting you identified another organization that's involved here. That was not in the video that we saw. These two price setters. It would seem every one of these organizations, and maybe there are more, all have to have some profit to exist. Are there parts that could be eliminated just to reduce the overhead? From your perspective, all of these different organizations between the manufacturer and the consumer, do you see organizations that could be eliminated and we would still have safe drugs?
Mr. Chairman, in the current setup and the current process, it would be a complicated endeavor to eliminate any player in that market. The wholesaler plays a critical role of acquisition of medication and distribution to their constituent or their vendor and their clients, the pharmacies. And they were produced by necessity because the amount of labor it took for a pharmacy before their inception was excessive. And there would be one or two employees at pharmacies back in the 70s and 80s that would do nothing more than order and maintain inventory and contact each individual manufacturer. So to say that they're an unnecessary step would be a misidentification by my perception. When it comes to the insurance, we see our value as a payer to offer benefit and opportunity for members to afford and access health care. From the pharmacy benefit managers, although their conduct and some of their behavior has been challenged and is deservedly so, I feel as though they do offer network as well as negotiation aspects that in a complicated process. And if their business model is attended to correctly, they can bring value to our payers. So I struggle to see where I could eliminate steps in that without massive overhaul and reconstruction of an entire process.
Thank you.
Any further questions for Dan? Thank you very much, Dan. Is there anyone else here to speak on this piece of legislation? Commissioner?
Mr. Chair, members of the committee, just wanted to get the information that I promised you after lunch. We were lucky. I know
Great help. Thank you. Anyone else? Seeing no one, thank you, members of the audience, for sticking with us and providing the valuable information. And committee members, thank you for, again, staying with us and being engaged. And we will adjourn for lunch and be back at 1 o'clock.
It's interesting here. I just find it reading the site. Average wholesale price.
And with that, are we starting with the video, Jen?
Yes, sir.
All right. That's why I bought popcorn.
The first thing to understand about biosimilars is that they are biological products. A biological product is a very complex product. It's produced in a living system, such as a bacteria, a yeast, or a cell. There's some inherent variability that's with that because it's a biological system. It's a living system. It's more difficult to control in the same way as you would something that's going to be chemically synthesized. Again, these are complex molecules that are more complicated to manufacture than what people typically think of in terms of a small molecule. And that does make the data package a little bit bigger than you would expect for something that would be a generic to a chemically synthesized product. For biological products, we didn't have an abbreviated approval pathway. So the only way to come to market was to have that full data package, which can be very expensive to develop those products. And you see that reflected in the cost of the products in the marketplace. So what happened in 2010 was that Congress signed a law that allowed FDA to approve biosimilar products. For folks that use biological therapies, either prescribers or patients, it's well known that these are very expensive products. So it's good to have that competition in the marketplace and ultimately that cost reduction to patients. A biosimilar product in the law that FDA needs to follow describes a biosimilar product as being a product that's highly similar to the product they're comparing themselves to that we call the reference product, and that would have been that originator product. So it has to be highly similar, and there has to be no clinically meaningful differences between the two products. So we look at the structure of the products, we make those comparisons about the structure, how they're functioning. So that first step is to do that analytical comparison or the structural and functional comparison to make sure that their structure is the same, they look the same, has the same primary sequence, same type of quaternary, tertiary structure that helps in its function. After that, we want to look more closely at whether or not there's clinically meaningful differences between the products. because those analytical comparisons can tell you so much about the molecule and so much about the comparison between the molecules and how similar they are. But there is some residual uncertainty that would remain about how it performed in the body, in a patient. So we look for additional studies, including what's called pharmacokinetics, and that's the exposure in the body. Does it release in the body the same way? Does it circulate in the body the same way? Is it getting to the same place in the same way to exert its clinical effect? And then we can look at other types of clinical tests with different types of endpoints where we would be interested in certain populations or certain diseases. We also look at differences in safety, making sure that it has the same safety profile between the products. And this all leads to the assessment. There's no clinically meaningful differences between the products. There's an expectation that when FDA approves a product, it will work the same way in the body, whether they take the reference product or they take the biosimilar. There's no clinical difference between the products. So FDA will not approve a biosimilar product if they don't feel that the data supports that they're biosimilar and ultimately that the products can be labeled for safe and effective use. So while the data packages between a biosimilar product and a reference product or an originator product are different, and that's where the concept of an abbreviated approval pathway comes in. FDA's standard to approve a product and be able to label a product as safe and effective for its intended use is the same regardless of the pathway. So the healthcare community and the patient community should have confidence that FDA is applying those same rigorous standards in terms of approving products and ensuring that they are safe and effective.
Are we going to see all three, Jen?
Nope, that's our, Mr. Chairman, that's our second one. After Mark's presentation, we'll launch our third.
Okay.
And I did send out to stakeholders and committee members links to the videos.
Whenever you're ready, Mike.
Members of the committee, Chairman Kaiser, for the record, Mark Hardy, Executive Director of the Board of Pharmacy. Representative Kaiser and Jennifer asked me to come forward and just give a short presentation. A lot of the information will be very duplicative of what you just heard, and including in the next video as well, but at least you have somebody that hopefully answer some questions for you on the emerging topic of biosimilars and interchangeability discussion. So biological products, as was discussed there, is a diverse category of products that are generally large, complex molecules produced by biotechnology in a living system. These things are very highly complex. I will show you a couple slides of how complex these molecules are, but they take a lot of very specialized manufacturing, and there's a lot of challenges in that manufacturing process to ensure that there's consistency in product. You're not, the traditional example you always point to is, a traditional drug. A traditional drug is chemically synthesized, traditionally very small molecule, and it's very easy to draw consistency from a chemical manufacturing perspective. These things are living cells in a lot of cases. Yeast, like was indicated, other things that are very basically cell lines that need to be replicated, and so that there's consistency in the product that is put out there in market, and it's delivering the same intended clinical outcome. So again, these things are originating from microorganisms, plant cells, animal cells. Some of the examples you may have heard of, obviously probably in different marketing advertisements, Epogen, Enbrel, Humira, Herceptin, or Sensia. But it also includes other things too. Vaccines, insulin's another one too. Insulin is technically a biological product, and a lot of the oncology medications. The reality of biologics and biosimilars, it's the future of therapy, the future of medicine, and the future of pharmacy as far as where those innovative therapies are coming to market. And with that comes extreme costs as well. So just kind of highlight a few statistics I pulled from a congressional report.
The cost of specialty drugs, including biologicals, are very high. The annual cost of some biologic medications in the United States, and I give 2 examples there, exceeds $250,000 per patient. According to the Genetic Engineering and Biotechnology News in 2018, 11 of the top 15 selling drugs by sales dollar amounts are biologics. Spending on biologics in the United States totaled $120.1 billion in 2017, a 12.5% increase in 2016. And the amount spent on the original biologics that would be subject to potentially competition through the biosimilar market is 10.2, and the amount spent on biosimilars in 2017 was 0.9 billion. And biologic spending has increased 10% each year since 2011. So some fairly, hopefully impactful statistics kind of shows the future of medicine and where it's coming. A lot of these different biological products are going to be designed for very narrow patient outcomes, very, very unique patient conditions that they may have. So obviously the patient base, it's not like a hypertension medication where we all have hypertension or a cholesterol medication where we all have high cholesterol. These are very narrow as far as their patient population in a lot of cases. So this kind of goes back to what was indicated in the FDA slide, but biosimilars. So there's biologics, so that's the actual, what would be equivalent of a brand name drug, but the biologic, and the biosimilar is theoretically the generic. And of course, the issue there is that they're not really truly interchangeable, and that gets into a further slide where we talk about interchangeability, and that's the ability to switch between two different drugs. So according to the Food and Drug Administration, a biosimilar indicates a biological product is highly similar to the reference product, notwithstanding minor differences in clinical inactive components, and also indicates that there are no clinical meaning differences between the biological product and the reference product in terms of safety, purity, and potency of the product. So just to kind of highlight the differences here as far as when we're talking about traditional drugs and biologics or biosimilars, you see a monoclonal antibody as far as the structure of that, and obviously that's a very complex, and you see the small structure below this aspirin. And so they're, again, very, very complex molecules. Another way to look at it is, the size of the chemical, and if you had some chemistry classes, it might bring you some bad memories here, but, you see the chemical compound of aspirin, Tylenol, and a medication there, and then you see some of the biological drugs, Lantus, which is an insulin, and then some of the larger biological products, just as far as the structure that we're talking about, and the number of carbon, hydrogen, nitrogen, oxygen atoms, and so on and so forth that are involved in these large drugs. So one of the emerging and very controversial issues right now in the industry is bringing biosimilars to the market. Currently, there's probably about, I think, a little over 20 biologics. I think I counted 23 biosimilars. There's 23 different biosimilars that are out there in the market. There's probably another maybe 75, 80, 100 biologics that are out there in the market. But the one thing that is very important about it is biosimilars versus generic development. Biosimilar development is much longer and it's much more costly than traditional generic drug development. It takes about $5 million for a generic drug, or about 3 to 5 years for that to be produced and brought to market. But for biosimilar, it's extremely more expensive, $100 million and up to 8 to 10 years to bring those things on average to market. So there's an extensive difference there, and there's different complexities as far as what patent protection they may get from the FDA as far as a branded biologic drug before a biosimilar can be introduced, and so there's other first string issues that are pulling at that as well, and which I don't know if it gets necessary for the conversation here. So just to kind of take a step back and just make sure we understand there's biologic, which is kind of that branded counterpart to biosimilar, which is made to be similar to the biological product. Now the ability, and the FDA has really struggled with this, and finally just in the last few months, actually May of 2019, they finally released guidance as far as the ability to interchange, so that interchangeability between a biosimilar and a biological product. And that means basically that you can switch back and forth and you should have no difference in your therapy. And the FDA has clearly studied this, and this is something that can be clearly done without any kind of negative impact on the patient. That interchangeable product is going to be a biosimilar product that meets additional requirements based on a federal law that was passed a few years ago. So again, it needs to show that it's expected to produce the same clinical result as a reference product in any given patient, and then switching between the reference product, the biologic, and the interchangeable biosimilar will be evaluated to ensure their safety and efficacy. And that was referred to as switching studies. So that's something that is an enhancement over top of the biosimilar approval that they need to prove in order to be an interchangeable product. So the FDA does state in their guidance, which passed out a couple of informational documents there, that what they intend is an interchangeable product may be substituted for the reference product without the involvement of the prescriber. And it's very similar standard to what traditional generic substitutions happen in pharmacies for traditional medications. So again, interchangeability is a much more stringent standard that needs to be met versus just the biosimilar designation that drugs are coming forward with now. And again, the FDA released that guidance in 2019, which should hopefully spur some development for interchangeable products out in the industry. So one of the issues, and kind of taking a step back, and I'll show you, there's obviously legislation that was passed in 2013, and then there was the definition of interchangeability in there, and kind of the standards for how you switch between those products. Obviously, back then there was really no biosimilars in the market, and there was obviously no interchangeability guidance out there as well. But the FDA continued to refer to a reference material, which is referenced in the law, that they would put out. They would say, this is what the practitioners out there can reference to determine if the product is interchangeable or if it's biosimilar. In traditional drug medicine, you talk about what we refer to in what's called the Orange Book. And that looks at Lipitor, Atorvastatin, and Zocor, Simvastatin, those things being able to be interchangeable and being equivalent, so that way you can switch between medications, brand generic, different generic medications to ensure they're bioequivalent, and that's something that can be measured. The same standard here applies on the Purple Book. The Purple Book is meant to list those products, the biological products, and then the biosimilars that are out there that have been approved by the FDA. And then furthermore, they're going to determine and place if those biosimilars will be interchangeable under the FDA and licensed by the FDA under that Public Health Service Act. So this is really the reference. Again, it'll be it is the gold standard for the medical community in regards to biological drugs. I linked up to the Purple Book. It's something that's available electronically. Let's see if I can just bring it up real quick. But there you can see that obviously very small, but it shows all the different biological products. And then it also will show on the slide here as far as their ability to be interchangeable or biosimilar. So B indicates that a product is biosimilar, and I would indicate they're interchangeable. Now you'll notice on all these pages there's no interchangeable product because the FDA hasn't deemed one to be interchangeable to date. And I think one of the main points that I think you all have to kind of struggle with here is that state laws enforced through the Board of Pharmacy dictate the interchangeability in practice. So it's something that, you're looking at the law as far as a legislative draft there on a bill, but that really is kind of the standard for what we would enforce as far as the interchangeability of biologics and biosimilars and their interchangeability. So again, that is referencing the law that's in place, and you obviously have a copy of that and a bill draft in front of you. Just to kind of quickly highlight timeline, 2013 is when the bill was enacted. 2015 is when we actually saw the first biosimilar approved by the FDA, Zarzio. And then May 2019 is when we finally got the interchangeability guidance and standard. And to date, again, no medications have been deemed interchangeable by the FDA. And just some reference documents, and certainly be happy to answer any questions you may have.
Thank you, Mike. Senator Rourke? Okay.
He answered my question.
Senator Elkins.
Mr. Chairman, Mark, The cost for doing the biosimilar comparison and research on that, is it the original company that developed the biological drug that does all that comparison and figures it out and gives it its blessing according to the standards of the FDA? Do they pay for that, or who pays for that?
Yeah, Chairman Kaiser and Senator Oki, it depends on who's making the application to bring it to market. Now, I think one of the unique things that and of course maybe folks from industry can probably better articulate this than I can, but it seems like the same company who's making the actual biologic product is also coming to market those biosimilars as well. So it's a little bit unique. You never see that often in the traditional brand generic market as often, but that is holding to be true here.
So there's not an independent research person that does the research on it and says, yeah, these are biosimilars now.
Chairman, and
we have the fox guarding the hen house on this stuff.
Chairman Kaiser and Senator, I don't know if I put it like that. I think.
Well, I'm trying to keep you simple.
Yeah. I mean, they have to do a certain amount of studies, and the FDA needs to validate those studies in order for it to be brought to market. So,
I mean, FDA's never been wrong before. They're great.
Representative Anderson.
Mark, I have a question concerning if you have a biologic drug, how long does a patent protection stay on that before you can do a biosimilar, or doesn't it matter?
Chairman and Representative Anderson, yes, there is some extended patent protection over top of some of those biological drugs that they give, just based on the, I think what they justify it off of is based on the enhanced cost of bringing these drugs to market. That to spur that development, they've given them an extended patent protection. I don't have the number in front of me. I can certainly report back to you as far as what that is. But then there's a secondarily further enhanced patent if it's an orphan drug or that treats a very narrow population base. And so that could potentially give that drug a little bit wider time period to have that patent. So that's
if you want to get the cost of drugs down, you basically got to have competition. But if you protect someone for 30 years, you know, the price of drugs are not going to go down because competition drives the price down. So,
yeah, Chairman Kaiser and Representative Anderson, I think that's you're hitting on a point that a lot of people are struggling with as far as how to make sure there's innovation in the market and we're bringing innovative therapies that are truly impacting people's lives. I mean, you think of pancreatic cancer. You know, pancreatic cancer not that long ago was a very, very difficult diagnosis. Nowadays, it's a different diagnosis based on the therapies that are out there. So, I mean, it's trying to strike that balance, which is very difficult, and I understand that. So,
Representative Casper.
Thank you, Mr. Chairman. Mark, I'm missing something in my simple hearing of what you are saying.
Yes.
What I thought I heard is the biological drugs are the current ones. The biosimilar are the ones that they're trying to make. And the biosimilar are going to be like the biological. What do we need biosimilar for if we already have biological? What's different about the biosimilars?
Sure. Chairman Kaiser and Representative Casper, so the biosimilars are really, if you look at the traditional brand generic kind of model of drugs, the biologics are the brand, the biosimilars are the generic. So there's going to be a decreased price for these biosimilars, and that's the nature of why they want to Representative Anderson's point, then you have further competition in the market that would hopefully drive the prices down on some of these medications. So that's I don't know if that helps you, but feel free to follow up.
I will if I can, Mr. Chairman. Thank you. So you just indicated that the biosimilars are 10 times more expensive to make. So where is the cost savings if it's 10 times more costly to make, and then you're going to put a patent on it for a number of years where you keep the prices up? Where's the savings?
Chairman and Representative Casper, I think the idea of where the savings would be is when you invite more competition into the market. So those biosimilars, and there'll be multiple biosimilars for those different products, and the ability to interchange those is what theoretically what they're thinking are going to help drive down the prices as far as
as far as these more expensive novel therapies.
So there'll be multiple companies developing biosimilars for the same biological drug?
Correct.
Senator Rohr.
Thank you, Mr. Chair, and Dr. Hardy. So you said, okay, so I heard 75 to 80 of the, we'll call it brand names, biologics, and then 23 biosimilars currently on the market, and 0 are currently approved as interchangeable. Is there a timeline on the FDA approving any as interchangeable? I just feel like right now we're a little cart before the horse.
Chairman,
there's nothing to swap.
Yeah, Chairman Kaiser and Representative Roars, or Senator Roars, excuse me. Yeah, I think that's one of the things. Now, the one comment that the FDA commissioner made when they deemed this guidance, they said, well, we expect a biosimilar insulin or interchangeable insulin will be available in the next 2 years. So I mean, I think there's the idea that some of these biosimilar products that are currently out in the market may go through this rigorous testing to get that interchangeability. But to your point, I would be completely guessing if I had any kind of future look at when that will happen.
Further questions for Mark? Senator Dunn.
Thank you, Mr. Chairman. Mark, I sponsored the bill in 2013, and the one point that is objectionable, and I'm not understanding, is telling the doctor that you're switching the medication. Now, I have a good relationship with my pharmacist. I have a good relationship with my doctor. They have a good relationship with each other. So if there's any question, they communicate with each other. Now, I understand that a biosimilar, you say, is highly similar, but it's not the same. And I understand that in a lot of medical conditions, it probably doesn't make any difference. But there are medical conditions, it seems to me, that it does. That when a doctor finds the right medication and the right dosage of that medication, that they don't want to deviate from that. So I'm having trouble understanding how it is that good communication becomes a barrier to getting into the marketplace. And these companies spend a lot of money developing the product, but they spend a lot of money marketing that product too. So I'm not sure, why, it seems to me that what we're arguing here is that the cheaper product would make it into the marketplace better if we just kept it secret from the doctor.
Chairman Kaiser and Senator Dever, I mean, I'm not arguing with you. I don't pretend to know. I think what you're faced with here from a bill draft perspective is developing and determining if you want to change that component as far as the state law, as far as what that interchangeability and what that process is. I think there's probably good reason and good merit to have a consistent standpoint from a generic and brand substitution across states, and the same would be true as far as interchangeable biosimilar to a biologic. That would foster, that would be beneficial to have a uniform standard across states. But ultimately, it's state law determined. So if the legislature wants that standard in place, then that's a standard you have in place. But again, that's all up to you to determine, and I'm sure Representative Kaiser, Chairman Kaiser, will be able to kind of give a little bit more perspective on the reason or the drafting of legislation. I'm just simply here to hopefully just kind of draw some light as far as what the industry looks like now from this, because when that bill was passed, to your point, there is no such thing as a biosimilar that was on the market. So the market's come a long way, and still to the point where we don't have an interchangeable biosimilar, but certainly we're marching down that path.
And Mr. Chairman, if I could just comment on that too. North Dakota was the first state to pass that law. I understand that in some other states that they've passed it with a little bit different language, that the doctor is still informed, but in a different manner. That is, the pharmacist doesn't have to pick up the phone and call the doctor, but they're informed through electronic records or something like that. And I understand that that's less objectionable to people. My concern is just that it seems to me that the prescribing provider is the one that should be calling the shots on that.
Senator Lee.
Mr. Chairman, I recall when this bill was passed, how long ago was it? Did you say 10 years or something like that?
2013.
Yeah, well, not even that. I didn't like it then, and I can't even see any reason for it now. It was passed at the behest of and under a tremendous amount of lobbying from the biologic pharmaceutical. And the majority of the voters in the legislature succumbed to that suggestion that this was going to be some terribly dangerous thing to patients, and I agreed with what Senator Dever has just said. So I'm not trying to be a jerk about this. I just don't see that there's any real benefit carving, we're back to carving out again, to carving out this particular portion of medical treatment as far as who's notified and how things go, because as Senator Dever has just said, I think the provider ought to be in charge, and I have confidence in both my pharmacist and my provider figure out which one of these might be the best thing for me if I need one of them. And so I didn't like the way it went down the first time, and I will have to be convinced it's still a good idea, whether it's the old way or the.
Further questions from Representative Wise.
Thank you, Mr. Chairman. And Mark, I guess just to be clear, we have 20-some biosimilars, but current law, none of them can be used in the state of North Dakota anyway, correct?
Chairman Kaiser and Representative, they can be used in North Dakota. The biosimilars can be used in North Dakota currently, but they would need you need to have a separate prescription for that biosimilar. So let's use the example of a hospital. If they had one of the biologic was ordered by the practitioner, and the formulary of the hospital only had the biosimilar in stock, then the pharmacist would need to contact the prescriber to say, is it okay if we use this biosimilar product, and get that authorization, because they can't be changed in their own nature. Okay, does that make sense?
Further questions? Senator Nelke.
Mr. Chairman, Mark, maybe you talked about this at the first meeting that I missed, but what are these biosimilars used for? I mean, are you growing new appendages with them, or you need a new liver, take this? What are they for? I don't, the words don't mean anything to me in your first paragraph.
Chairman and Senator, I understand that. For various ailments. I mean, there's a lot of medications that would be used in cancer treatments. Different skin conditions that some of those medications are used for. Even insulin for diabetes would be technically a biological product.
So just telling the patient don't eat sugar anymore isn't that'd be cheaper.
That would be cheaper. You're right.
Further questions for Mark? Right. Thanks very much, Mark. No problem. Is there anyone else that wishes to comment on this bill? Oh, we're going to present the bill first, and then.
Do you want to play the video?
Yeah, let's play the second video.
Specific drugs, like the first one we put in, helps grow perceptive is symptomatic breast cancer. I get those specific drugs, that's what
The purpose of the Biologics Price Competition and Innovation Act that gave FDA authority to approve biosimilar and interchangeable products is intended to increase access to these very important and life-saving critical medications to the American public. The Act defines an interchangeable product as one that may be substituted for the reference product without the intervention of the healthcare provider who prescribed the product. For an interchangeable product, beyond demonstrating that the products are biosimilar, so that data that supports that it's highly similar with no clinically meaningful differences, there are these additional statutory standards that need to be met. The first one is the expectation that the product will produce the same clinical result in any given patient. So again, it'll work the same way in any patient that's taking the medication. And FDA has approached that by saying that the application needs to include data or information to support that. That even if they're not seeking approval or licensure for every condition of use, every indication that the reference product is approved for, that what's in their application is sufficient to demonstrate that expectation So they have to give you data and information to address all the conditions of use for all the populations to show it wouldn't work any differently in any of the reference products labeled conditions of use. In addition to that, for a product that is administered to a patient or given to a patient more than once, that impact of switching back and forth between the interchangeable product and the reference product is evaluated in comparison to just staying on the reference product. So that is what we call a switching study. And that would be a pre-approval study that's conducted where you have a group of patients that's just given the reference product on whatever dosing or normal clinical schedule is given, and they're compared to patients who would go back and forth between the products. And then at the end of the day, you look and make sure that they have the same safety, the same effectiveness, it worked the same way, you have the same exposure in the body over time through that switching period. So you're not going to have any differences in between. And so those are the standards that we have to meet, that the applicant needs to meet, and the types of data that we would expect to support those standards. There isn't an expectation of substitution for biosimilar products. There is an expectation of substitution for interchangeable products. And that's why we look for that additional data and information, that additional evaluation to support how that product is going to be used in the marketplace. For a biosimilar product, if the prescriber writes a prescription for that biosimilar product and the patient took it to the pharmacy and said, here's my prescription, their prescription would be filled with whatever was written on their specific prescription from their provider. If it's an interchangeable product and it's written for the reference product, they can take that to the pharmacy and they may be substituted the interchangeable product, and that is that pharmacy level substitution. But it's important to remember that pharmacy level substitution is actually overseen at the state level, not at the federal level. So it's the state laws and ultimately the state boards of pharmacy that make decisions about the substitution of products, and that would include the substitution of biological products as well. If a patient has questions about the biological product they've received, they should talk to their doctor, pharmacist, and or insurance company to find out more information. So when FDA approves a biosimilar or an interchangeable product, healthcare providers and patients can rely on FDA's approval of that product. FDA will not approve a biosimilar or interchangeable product if it is not safe and effective for its labeled conditions of use. So we want to ensure the healthcare community and patients that they can rely that FDA is applying rigorous approval standards and manufacturing standards to both biosimilar and interchangeable products in the same way that they would apply very rigorous standards to the reference or originator products. The purpose of...
All right. When Jen gets back up, we'll go over the bill. The reason this bill is before you is simply that we asked Jen to look at our current law regarding biosimilars and to see if there would be anything that would present a hurdle, I'm not saying a non-surmountable hurdle, but is there anything in the law that is really not necessary, and that, therefore, we have the bill as it's presented to you. Yeah.
Thank you, Mr. Chairman, committee members. I'm reviewing 21.0011.01,000. And I think we've had a little bit of background on this. We're amending the law that was passed in, what did we decide, that was 2013? And we've got, I will walk through the section as it is today, and I'll point out the differences. We've got definitions of biological product, biosimilar, interchangeable biologic product, license and reference product. I think the videos and Dr. Hardy's testimony gave us good background on what those terms mean. And then we've got a definition of prescription. On page 1, line 13, we've got some housekeeping here. Those are the changes you'll see. It says a pharmacy may not substitute a prescription biosimilar product for a prescribed product unless. And then we've got a laundry list of A through E in our existing law. The first requirement is that the product needs to be interchangeable. The second requirement is that the prescribing the prescriber cannot have made a note that it is brand medically necessary. The third requirement is that the pharmacist needs to inform the individual receiving the biological product that the biological product may be substituted with a biosimilar product, and that that individual has a right to refuse the biosimilar product. On page 2, lines 3 and 4, we're removing the requirement that the pharmacist notify the prescribing practitioner orally in writing or by electronic transmission within 24 hours of the substitution. And then we have a requirement that the pharmacy retains a record of the interchangeable biosimilar substitution for a period of no less than 5 years. The final provision says the Board of Pharmacy shall maintain on its public website a current list and the internet link. I assume what this document is what Dr. Hardy referred to as the purple book. Is that, yep. So that there's a link to the purple book so you can see that items are biosimilar or that they're interchangeable. If there's any questions, I'd be happy to answer them.
Representative Cass.
Thank you, Mr. Chairman. Jennifer, by eliminating lines 3 and 4 on page 2, are we now not making the pharmacist the doctor?
Mr. Chairman, Representative, I suppose it's a public policy decision for you to make. I can tell you that in putting this together, one of the things I did was look at how we treat generics. And we have a similar provision in our generic law where the pharmacy is not required to notify the prescriber if it's switched to a generic. But there's also a requirement that if it says brand necessary, that the pharmacist use that brand necessary.
Thank you.
No further questions for Jen? All right. Yeah, any interested parties that want to comment?
Hi, good afternoon. My name is Angela Dockenauer. I'm the Director of Government Affairs for the Biotechnology Innovation Organization. I'm here to comment on the bill today. Thank you so much for this opportunity. So Bio supported the bill when it was written, Senate Bill 2190, excuse me, then, and it supports the language now. However, with removing the communication piece, we believe that that's necessary. And the reason that we do believe that that is a necessary portion is that even though interchangeable biologics will be expected to produce the same clinical result, it remains the case that patients could react differently to an interchangeable biologic than they are given the innovator product due to the complex nature of biologic products and how they work in the human body. In these circumstances, the treating physician must know that the products were substituted at the point of dispensing in order to appropriately assess a patient's experience and further treatment options. Moreover, it is the interest of public health to be advised of which biologic is being administered, as it will facilitate attribution to the proper product for adverse event reporting. Now that said, since the passage in 2013 of Senate Bill 2190, Bio has formed a coalition of chain stores, payers, physicians, patient groups, brand manufacturers, and generic manufacturers to develop 5 key provisions that should be included in the state's legislation. As the legislation stands, they're all included unless this piece is removed. Yet, what we did find is that we don't want this communication piece to be a hindrance to any sort of interchanging at the pharmacy. So in a few years past, we've developed language that would sort of ease that burden between the pharmacist and the physician. So the physician is still notified, but it doesn't put such onerous regulations onto the pharmacist. So what we developed is that once the product has been dispensed and the claim for payment has been adjudicated at the point of sale through either an interoperable electronic medical record system, electronic prescribing technology, a pharmacy benefit management system, or a pharmacy record, it is then presumed communication has taken place between the pharmacist and the prescriber. A phone call or other forms of communication would only be necessary if the above electronic means were not available. And as we know, the way that healthcare is going, these electronic methods are becoming more and more common in a lot of these pharmacies, if not, commonplace. Further, the communication language in Senate Bill 2190 as passed required the communication to take place within 24 hours. Now, while the electronic communication at the point of sale that's mentioned above is instantaneous, we understand that there may be some situations where a 24-hour requirement could be problematic. So BIO believes that a more reasonable time requirement would be 72 hours. BIO and our coalition members look forward to working with you in maintaining the important communication provisions in this legislation. Patients and prescribers need to know that what interchangeable biologic they received. So for those reasons, patient safety, cost savings, and complete medical record, BIO would ask the communication provision of the draft to remain with some of the changes that I mentioned in my testimony. And I'll answer any questions.
Any questions for Angela? Senator Elkin.
Mr. Chairman, when Mr. Hardy was up here and we asked him, or I asked him a question about what is this for, it was like cancers and that type of thing. I mean, if that's the case, I kind of doubt that 24-hour waiting period is going to make much of a difference. Or is there something new on the horizon that's a quick fix for somebody?
No, this is just talking about the communication piece. Sorry, Chairman, Senator. So it would be the communication piece. So as it stands right now, they'll need communication within 24 hours. So say, and we put the 72 hours in as sort of a safeguard for both the pharmacist and the physician. So say something happens and the electronic monitoring system or the electronic prescribing system is down, and it happens to be a Saturday and Monday's a holiday. So that 24-hour notice wouldn't be available for that person with that electronic record. Other than that, it is instantaneous. But it would give them at least it would give them a longer period of time to make the phone call or send the email or whatever when it comes to notifying the physician.
One more, is that effort also a way to help make sure that you're spreading the liability from the pharmacist standpoint?
Senator Chairman, I can't speak from a liability for the pharmacist standpoint. We look at it as sort of in many years of passing these pieces of legislation in other states and working with some of the interested parties, we've kind of come to this conclusion that it's a time frame that everyone can kind of live with, at least in a lot of the other states that I've been involved with.
Well, but it's crossed out in the bill right now, so they wouldn't have to notify.
They wouldn't have to notify.
You'd like to have it back in, and that was my question. I think that's what I was referring to. Is that to kind of help make sure you've got someone else on the hook for liability too, not just the pharmacist?
Chairman Senator, I'm not entirely sure that it would be, I'm not a lawyer, so liability-wise, I can't really speak to that, but I do think that
there's
it's...
a lawyer right there.
Do you want to take that? I think that would have a component in it, but it also has to deal with sort of the physician and patient relationship as well as the pharmacist and patient relationship. So everybody's in the same boat when they know what the patient is on ultimately at the end of the transaction.
Thank you.
Further questions for Angela? Angela, how many states have adopted the new language that you proposed?
There's varying, so there's a couple states that passed language before this coalition was created. So right now, DC and Oklahoma are the only two states that do not have a biologic substitution law in place. That said, they do run sort of between 5 days for communication to 72 hours for communication. But the majority of them, I believe there's 5 or 6 that we have to go back in and hopefully change it so that it makes it easier for the pharmacist and the physician to communicate. But once the coalition came to this language agreement, we went into the other states and had it in this manner.
So you actually are advocating making a change to our current legislation and adding the language that you were proposing?
Chairman, yes. If you're going to open it up and take this out, we would rather have this communication language that is going to be mirroring the rest of the states when it comes to the substitution and communication.
Any further questions? Thank you very much. Is there anyone else here to address the committee on this bill? Senator Madden.
Mr. Chairman, I was wondering if there is a consequence, a major proportion to our, let's say, our Medicaid population or our responsibilities there. I'm wondering if we could hear from Dr. Joyce as to this bill. You know, is this helpful or not? Because that's a big population that we pay medications for.
Chairman Kaiser, Senator Mather, members of the committee. I was here in 2013 for Brendan Joyce, the pharmacy administrator for Medicaid. I was here in 2013 when the bill went through. And at that point in time, there were no biosimilars, but the bill went through. So it was preemptive, getting in place before it needed to be. I heard a couple of comments about, the interchangeable ones aren't out yet, so are we doing this too soon? I believe Senator Roars, you had mentioned that. But it's keeping in line with this bill. It was in place before it was needed. The changes could be in place before it's needed. As far as requirements to notify the prescriber, I'm not a prescriber. I guess I've done the stuff for Narcan if I need to do Narcan prescribing, but I'm not a prescriber, so I can't speak to necessarily what the prescribers want. I do know that prescribers have issues with paperwork at the moment and notifications and a whole lot of things coming through their electronic medical record and constantly saying, hey, we need this, getting notified about this, getting notified about this. So if I was a prognosticator, I would say as time goes on, and again, this is for the interchangeables, which are going through extra FDA certification to ensure that they are truly interchangeable and switchable, can go back and forth between them. The FDA considers it the same as generics. Over time, as the interchangeable ones have more experience and everything else, I could see that the prescribers would say, stop telling us. We know they're interchangeable. We don't need to know. Now, Senator Devers' comment, where they, as of right now, they probably want to know. But over time, let's say there's insulin ends up with interchangeables. There's a lot of people on insulin. And there's going to be a whole lot of notifications. Every new prescription that comes through, if there's a notification requirement, it will be another added thing for the prescriber. So at some point in time, whether that notification piece is kept in or left out, at some point in time, I'm fairly certain that if it's kept in, they will request to take it out. Once the confidence and the experience with the interchangeables is at that point in time, and I can speak a little bit to the memory of when generics first started. It was the same deal for just generic molecules. The lorazepam and Ativan, or diazepam Valium. And they said, no, we need to know. Eventually it got to the point of comfort that they did not need to know anymore. They knew that the generics were equivalent. So that's my general take on it. It's definitely a policy decision for the legislature to decide what is in place this next go-round.
I guess I was wondering, what is the consequence to the Medicaid population?
Chairman Kaiser, Senator Mather, anytime there's extra steps to take, there's a chance that those steps won't be taken to save money. And there's going to be some times where the interchangeables aren't more cost effective for Medicaid and will have a prior authorization to require that they use brand name instead, the actual original biologic. So it's hard to say what the impact will be, but in general, if there's more steps to do something, it's less likely for those steps to be done. It will be easier for the pharmacist getting the Medicaid recipient's prescription. If it's for the biologic, they're going to get paid enough for the biologic. They were going to do the biologic, because why go through the extra steps?
Thank you.
Any other questions? Thank you. Is there anyone else here that wishes to testify? Anyone from the public? Committee, your thoughts, discussion? Senator Lee?
Mr. Chairman, I just have to bring up one thing. When you talked this morning about the report on catching a glitch in coding and as far as the billing was concerned, the reason you knew about that is because Dr. Joyce found it in the Medicaid expansion prescription drug stuff. So we have Brenda to thank for the fact that that was discovered and it's now going to have a big impact on a whole lot of people. And I thought you deserved a little credit for that.
Well, committee members, it's interesting that the physician has, or the provider, it's not physician, it's provider, because we have nurse practitioners and physician assistants that prescribe, that the provider can, at any point, determine medically necessary. And if you want it to be done, you put down medically necessary. You're in control. You're in the driver's seat. And yet, we're asking them to go through additional standards of testing to make sure they're basically identical. And then to worry about, and if not changing this, then certainly to modifying it to what the coalition, because it works on both ends. The pharmacist can say, I don't care. Yeah, it's going to save Medicaid $200, but that's what it is. That's what I'm doing. Because I'm not going to go through all the hassle of notifying. So it's a two-sided street here. And this is really attempting to look at, are there ways, at least the proposed amendment makes it a lot simpler. Most of our folks are on electronic records, and if that's all they have to do is enter it, that's easy. But if you need me to call you every 24 hours, I'm not going to do it as a pharmacist. That's pretty easy. Senator Warren?
Thank you, Mr. Chair. I think there are a couple points that were made that are sticking with me. One, Dr. Joyce's comment about how when we went to generics back in the day, people needed that comfort level with the generic before they were ready to say, okay, just do it automatically. And I think that might be where we're at today. So I do take the BIOS proposed amended language to heart, that this might be a nice middle ground until there are actually interchangeable drugs and this starts happening on a more regular basis, to just allow people. Also, I just think about from the provider's perspective, I prescribed a drug and I know that my patient is taking a drug, but I don't always know exactly which one that is. And so I think that there is some benefit in at least being aware that it was switched, so that if they're having problems, I know that it was with the generic version and not with the brand name version before I switch them to a different drug. I might try them on the brand name specifically, and if that doesn't work, then now I try a different class or a different category. So I do like the amended language as a nice middle step.
Further committee discussion? It's also intriguing to me, having served on the Sanford board, that the larger healthcare facilities have clinical pharmacists operating on the floors and dictating what will be prescribed, literally, and the providers are deferring to them. So I find that really an interesting contrast to our discussion here. And those of you from large facilities, you know that's true. So, well, committee members, we won't take action on this bill. We'll, I think, draft it in the amended form and have it back before the committee at their next meeting, where you can look at it with that language in there, because you don't have it right in front of you at this point. But
Chairman,
Senator Holt.
whatever I am.
If you didn't switch, it would be so much easier.
It would be so much easier. But now it's much fun. I wonder, we also haven't heard from the medical providers. Do they have feelings about it? Maybe we want to get Courtney or someone from...
I'll tell you what, just as a courtesy to Courtney, we'll ask her to be here next meeting.
Okay.
She came up to me and said she wanted to do a little more assessment.
No, as long as the next week. I just think we need, that's a voice we didn't hear today that we need to hear. You have another time.
All right, sounds good. All right, moving right along. we're now at lunch. I'm skipping lunch and going into a presentation by Chris Jones, the Director of our Department of Human Services, addressing the state's role in identifying social determinants. Welcome, Chris.
Thank you. Chairman Kaiser, members of the committee, I'm new to glasses, so I'm going to be really distracted. I apologize. Wanted to spend a little bit of time. I understand at the previous committee hearing there was talk about social determinants of health, and really one of the agencies that plays a big role in social determinants of health is the Department of Human Services, and kind of wanted to give people an idea of how it all fits together, or sometimes doesn't fit together, and then follow up with a presentation from Lutheran Social Services on one of the programs that does fill a gap in social determinants of health. So you'll hear often, even yesterday at GNDC, I believe Dr. LeBeau said that one of the greatest costs or driving the cost of healthcare up is I would say, lack of focus on the social determinants of health driving the cost of healthcare up. So if you think about health outcomes as quality of life and length of life, those are up there at the top. But in those blue boxes, the health behaviors, the clinical care, the social and economic factors, and physical environment, those are kind of the 4 key components to health outcomes. And this is a well-researched academic model as it relates to the resources that are necessary or the impact these things have on the social determinants of health that ultimately drive health outcomes. So obviously you need clean air and water, and you need housing and transit. That's about 10% of our health outcomes. The social and economic factors, those are really what we'll be talking about today, the social determinants of health, but those are things like education, employment, income. And then clinical care, oftentimes we look at clinical care as being really important, kind of a pillar or the nexus, but it really only has about a 20% impact on overall outcomes. And that's not only the quality of care, but also the access to care. Those two things go together. You can have great access and poor quality, and you're not going to have the same impact. And then health behaviors have about a 30% impact on health outcomes. And I believe there was even a poll that was done at GNDC yesterday as it related to the affordability of healthcare, and the general consensus of the audience was that health behaviors is really driving the cost of healthcare up. So, but all of these things work together. But what DHS does is we only exist when there are gaps in those social determinants of health. So in a perfect world, if communities had all of the social determinants within their own communities, whether that relates to education, food, social, and community context, if the community was able to provide those, and I'm using community broadly, DHS would not have a role in the state of North Dakota. So we are only filling the gaps for people who are experiencing poverty and vulnerability. So our goal really should be to not have people experiencing poverty and vulnerability, but at this point, those things do exist. As you can see, it's the community resources that shape and enable access to the social determinants. So schools do that, the healthcare system, the housing market. So investing more in community resources can ultimately reduce the overall cost of what the state has to spend through the Department of Human Services for social determinants of health. So this is to give you an idea of how DHS works to fill those social determinants of health. If you look on the far left-hand side, you will see those social determinants of economic stability, education, food, so on and so forth. And then the components that fit within those. So if you take economic stability, you have employment, income, etc. What we do is take it across, into the middle you see the social services and eligibility within the Department of Human Services. Medical, DD, and long-term care as another pillar, and then behavioral health policy and services. We tried to outline the things that the Department of Human Services administers versus those things that we are a payer for or those things that we partner in. And I realize there's a lot on this slide, but ultimately these are all the social determinants of health that where there's gaps, this is where the state steps in to provide these services. So, for instance, in the food category, when there is hunger or access to healthy options, there's SNAP and food stamps in the social services world. In the medical and DD services, there's nutrition services that are provided within that pillar of the agency. And then under behavioral health, there's the recovery support services, and oftentimes food is a necessary requirement to provide for those things. By no means is this meant to be all-encompassing of everything that happens. This is illustrative in nature, but it is the majority of things that happen within the Department of Human Services. But I would also be remiss to say that if you look on the far right-hand side, we work with agency partners to help deliver these social determinants as well. This is not just DHS does this. This is we need to work with labor and job service on employment. We need to work with public instruction on schools. We need to work with corrections and juvenile justice as it relates to the foster care system. So you start to look at where the investments are made and how we do that. And we are only, I can't stress this enough, we are only filling the gaps that exist today because those resources don't exist in the community today. So ultimately, if we're being really thoughtful, we should be, how do we build up our communities so that they are supporting everybody in that virtual community so that these services aren't going to be as necessary. But unfortunately, they still are. And so when you break this down, now this would just be where the dollars go within the Department of Human Services. So up on the top, you can see the support item. That's just the, my salary is right in there. But then below that, you have social services and eligibility. That's where the vast majority of the social determinants of health are being met as they're delivered through county social services. And so that is SNAP, that is LIHEAP, that is foster care. Within that paren of social services and eligibility is about 1,100 full-time equivalent employees who are delivering those services. The next paren is medical DD long-term care. That is, in essence, Medicaid as the payer. So that's where the majority of money in the Department of Human Services is at, is paying for those claims, whether that be for medical claims in the hospital or for being in long-term care, or for those individuals who are living in the community with a developmental disability. That's where all of that money is going and gives a proportion. I want to stress, though, this is just a DHS view, because if we're looking at this purely from a citizen focus across the state of North Dakota, the variance would be a little bit different, because if you start to add in corrections, you add in local public health, they play a role, and some of those social services and eligibility from a local public health would be a little bit more money. And then on the bottom there, you can see the Life Skills and Transition Center, the Human Service Centers in the state hospital, which is overall a very small portion of what we spend in aggregate in DHS. But as many of you have heard me testify, when we talk about DHS, we always put the citizen in the middle, the person in the middle. What do they need? How do we best serve them? How do we serve them in the least restrictive environment? And not only do we serve them in the least restrictive environment because that's what they want, there's also the added benefit of oftentimes it costs the state less money to do that. So it's a win-win situation. So what I wanted to point out specifically on this slide is we look at the number of clients we have in each one of these programs in the state of North Dakota, what the cost is per month, and then what we spend per month. And Lutheran Social Services is going to come up and talk about something about how do we keep kids from going into foster care. So I just want to walk you across the foster care program right there. You can see we have approximately 1,200 kids in foster care, traditional foster care today, at a cost of $1.3 million per month for those 1,200 kids, or $2,700 per month per child. So when we look at these things, if you can keep a child out of foster care and keep them in their family, aside from their outcomes as it relates to behavioral health, their success in school, and filling all those other social determinants of health and having a better chance of a greater outcome, when you look at what we could invest in programs like what Lutheran Social Services have, we're actually saving money as well. And the more things we can do to fill the gaps of social services and prevent people from going into institutions, institutions are some of our highest cost areas where sometimes they have a place in the continuum, but they are the highest cost of care. So if you look at, if we are able to meet the social determinants of health of an adult with a developmental disability by providing education supports, employment supports, housing supports, we can, in essence, spend and keep them out of Life Skills and Transition Center. We will save $31,000 per month on that individual. So there are times I think people think of social determinants of health as being just pure welfare and handouts. And there are times that there is fraud in the system. I'm not going to tell you that there's not. But if you're looking at it from a pure return on investment, oftentimes it's going to be in the state's best interest to provide access to those gaps in social determinants of health in those families who have some instability, or in for individuals who are trying to remain in their community. That is I can't stress enough, it is a win-win situation for that. With that, I'd be open to any questions.
Any questions for Chris? I don't see any. Thank you very much, Chris. Next on our agenda is Janelle Regenwald. Is that correct? Or Dan, you're going to introduce her? Thank you.
Oh, I'm just going to pass things out.
Oh. Welcome.
Thank you very much.
You have a lot to live up to. Dan, told us about you, and so I'm excited that you're here. Thank you for coming.
Thank you, Chairman Kaiser and committee members. My name is Janelle Regenwald. I'm the Vice President of the Children's Services Division at Lutheran Social Services of North Dakota, and I'm providing testimony today sharing about an effective example of an evidence-based program addressing health drivers. As you heard earlier, and I understand you heard at your last meeting as well, social determinants of health have been well established. You know that based on studies and also just conversations in academic circles. Yet I think what may be more hidden are examples of specific human service delivery methods and programs that help address a variety of these determinants. It's far easier to identify a single barrier, such as transportation, and how to address that particular barrier than perhaps it is to see a multifaceted approach that can deliver a myriad of positive outcomes. If you take a look at the diagram in the bottom of page 1 of my testimony, you can see an example. This comes from the American Academy of Pediatrics, and it's a roadmap to address the social determinants of health through community collaboration. And you can see the various risk assessments there on the left and how that corresponds to Maslow's hierarchy of needs. But then look at the right side where it shows a variety of community-based interventions. Now, I'm not a healthcare provider, but I can only imagine as a physician knowing the importance of and the value of collaborating and recognizing social determinants of health and working with your patients. But then how do you, in the time that you have with your patients, collaborate with all those various individuals that are going to help you address those determinants? And so I think for that reason, it's important that I come before you today to talk a little bit about a specific example, because there are examples out there in the delivery system today, and there's potential to have more of those that help address across outcomes and not in those siloed kinds of things where if you have somebody that has this issue, you have to connect with this particular provider. I'd like to share with you the specific example of the Healthy Families America model of home visiting. As you heard from Mr. Jones, we are one of the providers that works with the Department of Human Services to address social determinants. This particular program is funded partially through the Department of Human Services and under the Children and Family Services part of the budget. So you can think about that as you saw those graphics earlier. But we are a model of home visiting, a method of delivering services to families that address so many issues that we know to be important. The Healthy Families model of home visiting is rooted in the belief that early nurturing relationships are the foundation for lifelong healthy development. Interactions between families, support specialists, and families are designed to promote positive parent-child relationships and healthy attachments through strength-focused, family-centered, culturally sensitive, and reflective practices. This particular program is specifically designed to support parents who may have histories of childhood trauma, intimate partner violence, poor mental health, and or substance abuse issues. I know as I look around the room and having testified previous times before in many sessions that you are knowledgeable about adverse childhood experiences and the impacts that that have. And so we're really talking about the impact of adverse childhood experiences as well. Families are typically enrolled prenatally or within 3 months of birth, and once enrolled, services are provided. We are with that family until a child's 3rd birthday, and at times can even offer services up until the child reaches the age of 5. We rely on well-trained staff, intentional curriculum, and evidence-based strategies to strengthen families and help them achieve their goals. Really healthy families working with the age group that we work with and families at the point that they are at really captures the teachable moments when families are most often open to learning, because it's at the time that they have a newborn. And we can get in front of them and work with them before adverse patterns are established. It's important that you know that the program is free and also that the program is completely voluntary, and it is not based on income. Thereby, it minimizes many barriers that families face in reaching supportive services. We build on the strengths by teaching evidence-based strategies to reduce stressors, develop resiliency, establish solid attachment to their children. And in this way, the program gets at the core issues that at-risk families face daily. Things like budgeting, anger management, healthy relationship choices, nutrition, long-term planning, and problem solving. Healthy families gives them the skill not only to cope, but to thrive, and reduces the continuation of child abuse and neglect for the next generation, and therefore gets at some of those costs that you heard Mr. Jones talk about. The program is really engaged in a variety of things. You'll see a list on page 3. It talks about a number of screening and assessments to determine risk, which we know is very important. And it's important to know that in home visitation programs like this, those screenings and assessments aren't happening just at a single point in time. They're happening over the duration of the family's participation with the service provider. And those risks shouldn't just be assessed at one point in time. For example, someone just shouldn't be assessed at one time about postpartum depression because that risk continues for a period of time, or developmental delays of a child. Home visiting is the core of what we do, but we do a lot of screening for child development, maternal depression, and intimate partner violence. We run parent support groups, and we very much hold up the importance of and the involvement of fathers in our work. Our program aims to reduce child maltreatment, improve parent-child interaction and social emotional well-being of children, increase school readiness, promote child physical health and development, promote positive parenting, promote self-sufficiency, increase access to primary care medical services and community services, and decrease child injuries and emergency department use. So by taking a look at that list, I think you can clearly see the connection between what we do in home visitation and the importance of the healthcare industry drivers. Lutheran Social Services has been delivering this home visitation model since 1999. We first piloted the project in the Grand Forks area as a response to the stressors following the Great River Flood of 1997. And at that time, we joined together with others in the community, knowing that so many of our communities were severely impacted and as a result would be at greater risk for things like child abuse and neglect, drug abuse, mental health, and other health issues. The program later would expand based upon the recognition of all it contributed to a wide variety of positive outcomes. We began serving Burleigh and Morton counties in 2008, and most recently in April of this year, our reach increased to 11 total counties as we added 7 new counties with the addition of Walsh and Pembina to the northeastern area and 5 counties surrounding the Watford City and Dickinson area, all with the support of a private philanthropic organization. This two-generation approach of serving parents and children together has a unique double-edged benefit. Research has documented that a parent's education, economic, and health stability can positively impact the health and well-being of a child. However, you maybe haven't thought so much about how similarly a child's education and healthy development is a powerful catalyst for parents as well. We know health starts in our homes, schools, and communities. That's at the root, social determinants. And the Healthy Families Program impacts the child right from the start with our beginning and prenatal and right after birth approach. When we break down social determinants of health into their areas, a program like Healthy Families has far-reaching impact around things like economic stability. There's employment goals in many of our families that we work with. There's also financial literacy that's built through active teaching and assistance. The physical environment is impacted through safe and affordable housing being maintained and in some cases obtained for the first time, and assistance in having a safe environment for an infant and toddler. Early education is an integral part of the program, and helping parents with their educational goals is another part, knowing that it's a time that they're highly motivated to be the best that they can be as they begin parenting. Food is an important social determinant, and our program promotes breastfeeding, healthy nutrition for both parents and children, and assuring food security is another high important area. Not to be forgotten is community and social context as an important part of determinants. We build social capital for participants by linking them to other connections and fostering relationship with other parents through participation. Social isolation can definitely lead to anxiety, depression, substance abuse, and overall struggles with long-reaching negative impacts to not only parent but also child due to the impact on a parent's ability to read cues and respond to their children's needs. The strong positive relationship that's built over time between family support specialist and parent helps protect against this isolation that can be even a higher risk at time of first parenting. And last but not least, the healthcare system. Connectedness to healthcare providers can be strengthened by the establishment of a medical home, which is one of the things that we do, which reduces barriers and makes sure that our families stay up to date on their well baby checks, immunization schedules, and don't over-rely on emergent care when they have needs because of that link to a positive medical home. The early identification and issues of delay leave a significant impact too on the healthcare delivery system. And with the ongoing screening that takes place in a program like ours, we're able to get help into those families at a much quicker rate. Currently, there's many exciting developments that may pave the way for greater support of these programs. The Families First Prevention Services Act on a federal level, that's right in the midst of what's happening right now, and that should further promote a program like Healthy Families and others like it. And payers becoming more willing to recognize the values of models such as these that address the social determinants, as well as various pay-for-outcome methods, may all contribute to a further commitment to fund these services, and hopefully to fund those beyond the pockets in the state that currently where it's provided have been more driven by private sector commitment to grow to a more adequate scale, allowing for parents, regardless of zip code, to have access to home visitation. As an organization that's served children and families across North Dakota for 100 years, we see the immense value in this service, and we know others do as well. We'd strongly encourage your support to think about ways to allow for payment of home visitation services like Healthy Families. Right now, as we mentioned, our primary funding source to about 50 to 60% of any of the funds that we receive to run these home visitation programs come from the Department of Human Services. The remaining 50% of each of those locations is primarily made up of a patchwork quilt of ways of trying to string together the dollars to make sure families get the necessary support. I'd be happy to answer any questions that you may have at this time.
Thank you, Janelle. Senator Madden.
Thank you, Mr. Chairman. And Janelle, for some years now, we've had these services available in certain regions of the state, but not across the whole state. In light of the social determinants of health, and this being one way of addressing healthcare costs, do we have any data yet that says where we've done it, healthcare costs are less than where we have not?
Chairman Kaiser and Senator Mathern, members of the committee, when we look at some of the data that we've been collecting, and we also look at national data, I think one of the most difficult subjects is we don't have any of our current programming at any critical level of scaling to maybe have the kind of impact that we could have. And I will give you an example. Here in the Burley Morton area, we have a little over 2 FTEs providing service in a 2-county area. Just as of today, I'm going to get my numbers correct here, we have 55 families waiting to get an assessment. And of those, on top of that, 10 families who we've assessed who screen into the program and direly need the service but we don't have the support of personnel to be able to meet that demand. And that doesn't even touch the demand that there could be. You know, I mean, we're still really doing home visitation on a relatively small scale. So as much as we now can profess that we are in 11 counties, we aren't able to provide home visiting on a universal level to every new parent. You know, everyone who parents a child. It doesn't always have to be a new parent, meaning for the first time. On a national level, and as a part of Healthy Families America, which is an evidence-based program, and they do a lot of research, there are a number of data points that show some really great incomes of making a difference. That we know we are having that same kind of impact in North Dakota, but again, on a much smaller scale, given our numbers. And just a couple of examples, you know, on a national level, the research shows that a program like ours has reduced the rate of low birth weight births by 48%. That we have parents in our program more likely to continue their education, and they're 7 times more likely to complete at least 1 year of college. So those would just be a couple of examples of some significant data. And I'd like to leave you with one last one, and that's, you know, talked about the importance of the return on investment and not having children progress into the foster care system. In a program like Healthy Families, in the screening process, we know that we are working with a higher risk group than the general population in order to receive our service. And yet, time and time again, since beginning our program, we tend to have very few families that ever progress into having a child enter into foster care while they're working with our program, and even for a period post that. And keep in mind, that's when a home visitor is coming into their home very regularly. And we are mandatory reporters of child abuse and neglect, so we would most definitely raise the red flag when those situations occur. And those situations rarely occur for us, even though the risk group is high. So we tend to be, you know, operating with a higher risk group with a lower propensity to that. And I would say that it's directly related to the supports that we provide and the positive impact of the social determinant address that this program can do.
Other questions for Jim? Oh, Senator Hogan.
Thank you, Chairman Kaiser. Like Senator Mather, I'm interested in the research, and Healthy America Families has data. Could you send us a link to that? Because I think it's really powerful data, and it's always good to see it. But it kind of blew me away when you said you've been doing this for 20 years now. It's like, I remember when, that's how long we've done this. But have you done any longitudinal studies locally, even though you have a small sample size? Have you tracked your families and done any research at the local level to talk about your local impacts? Or is your sample size just too small?
Chairman Kaiser and Senator Hogan and members of the committee, we would love to be able to answer that with a yes, that we've done that. The funding that it would take to do that, given we don't really even have adequate funding to staff up to capacity, is difficult. So we've certainly participated in some research projects. We provide our data to the national office. So when we share some of that national data with you, you know, we're a part of that. Okay. We turn our information into the national HFA because we're accredited through them. They ask those types of questions.
Then the other piece is there are a number of early childhood support programs. I'm thinking the Family Nurse Practice Partnership Program in CAS. So there are other programs that are like that. And now the new Jeremiah program, which is an intensive 2 to 3 year support for single parents. Is there a network of the providers that are doing this early intervention, and how do you work together?
Yes, Chairman Kaiser and Senator Hogan. See? It's hard to keep that senator versus representative.
It's my fault.
Yes. There is a statewide coalition of home visiting groups, which it includes people like Early Head Start, the Family Nurse Program, and other early childhood educators. And that way that group can collaborate, keep each other informed. You mentioned the Family Nurse Program. That also is evidence-based. There's a relatively short list of evidence-based home visiting programs, frankly. There are others that happen that aren't necessarily have that stamp of approval of being research proven. But FNP and the Healthy Families model do meet that criteria.
And do you gather? Do you all, because, you know, you talked about the areas that you're covering, how much of the state is covered? Do you have any sense of that?
I know that recently Family Nurse has expanded to this Bismarck area, more rural than just Burley and Morton. I'm not certain of the exact counties that they're expanding into, but that's ever evolving. But still,
we're still
not even half. I mean, my best guess is maybe 20% of the counties have an evidence-based home visiting program.
Thank you.
Further questions for Janelle? Thank you very much, Janelle.
Thank you very much.
Great to have you here. Is there anyone, any interested parties in the audience that wish to comment at this time? Committee discussion or directives on this issue? Is there anything you would like us to attempt to schedule for the future on this subject matter? Senator Lee?
There, I got the button. Yesterday in the forum, and perhaps one of the other forum readers might recall, but Sandra Roars is a part of there was a long column in the paper, and I want to say family, whatever.
A mentorship program.
It's a wonderful mentorship program that has gotten a big grant. And it's from, I thought it was from birth or infancy through 12th grade, that there will be a mentor that accompanies these kids. And I'm looking for it. I know I saved it, but without my laptop or my iPad here, I can't find it on my phone. But that would be another tool in this, and it sounds pretty interesting. So it would be kind of cool to, not to have them come, I realize we can't hear everybody, but it's another tool in the toolbox, and we're trying to.
Well, we'll check into it.
I'll find it.
If you can find the name and give it to Jennifer,
He
that.
wants to say something.
Good.
For the record, Chris Jones, Chairman, members of the committee, we've actually started working on all of these studies, and quite frankly, what we're learning is there's been a number of longitudinal studies on all these things that actually go back to the 1960s. And now there's enough information that, I mean, obviously North Dakota is special in its own way, but for instance, Nurse Family Partnership, NFP, typically has had greater success with the Native Americans. This other family program that was being talked about, I mean, there's different profiles that are out there. And I think sometimes we get lost in the, let's see if it works and let's study it. I mean, these studies have been going on for some time with very great information. And I think even as we start to look at even the people who are using these services, and I didn't do a very good job explaining this, the vast majority of people who are experiencing poverty experience poverty as a child. And it is a cycle that goes over and over and over again. And so the real challenge is how do you break that cycle? And that cycle is broken in a number of different ways, but one of the best ways to break the cycle is through education. Education not only for the adult, but also for the child. And so there's going to be some more work as it relates to how do all these things fit together. Because one of the number one determinants of whether or not someone over the age of 18 is going to be incarcerated is the number of words in their vocabulary by the age of 5. So if we're going to be serious about driving down the cost of the things that we're doing, that's how we have to start using these. We have the data. It's just a matter of how best do we use it, and can we put some of our feelings about certain things aside and use the research on how to do this, because it does all exist. And I'd be more than happy to provide Jennifer Clark the kind of the 3 or 4 key research studies as it relates to using social determinants of health to reduce intergenerational poverty, which it ultimately is going to reduce the state's use of gap filling within DHS.
Senator Lee?
Mr. Chairman, Senator Dever found it, and it's Friends of the Children. I just forwarded it to you and to Jennifer. I can't off my iPad do the group. I go to the whole committee, but it's Friends of the Children, and it talks about research showing that economic status is a major predictor of how well a child will do in life, and foster care, and 50 kids in Fargo-Moorhead, age 4 to 6, are in foster care on any given day. Anyway, it's an interesting article, and it talks about how this has worked in other places, and they have received this grant to allow that $850,000, as a matter of fact, from the Stand Together Foundation to launch a new chapter of Friends of the Children in the Far Memorial area. And yesterday, the director of Friends of the Children was at the educational exhibitions things for the chamber locally and gave just a minute about this as well. So it's one more interesting tool that we have. And thank you, Senator.
Great, thank you very much. Representative Dover.
Thank you, Chairman Kaiser. Mr. Jones, I have just one quick question. Do we have some sort of mapping of all of the different home visiting services and services similar to this, investing in the home in children, so we could sort of see, are there portions of North Dakota where we have gaps? Because there's so many different folks providing these services. Is there something comprehensive like that that exists anywhere?
Chairman Kaiser, Representative Dovich, not now, but we are starting to compile that, partially as we do the social service redesign work. But also as we use the constraint methodology, it's like, where are the gaps at? And then last session, or the session before last, Ms. Agnes made sure that in many of our contracts that we do, we are going to start to have outcome measurements as it relates to those contracts that we do. And so we're also developing those as well, because we may be providing grants to organizations that just aren't getting these outcomes. And we need to pull that money away and put it in someplace else for immediate return on investment.
Thanks. Any other committee comments? Committee, I think it was the Sunday morning show this last Sunday that had the feature, and I thought it might be interesting. We will investigate the possibility of asking the Department of Education to come in and talk about these general issues. I believe it was that show that had the segment, and interestingly, over 50% of the prisoners in the United States are diagnosed as adults with dyslexia. And you wonder why they go to prison. They can't read. And they fail within our system. And, you know, we have, and these are all important social determinants, but maybe we should be looking at the diagnosing that's going on within our education system and other programs as well. Because if that's true, it seems to me we need to have pretty early intervention in other areas than, I don't think, Janelle, your program deals with dyslexia, but I don't know, it might. But that was startling to me. So we'll investigate that. Any other suggestions? All right, well, thank you very much. We'll move on to the next item, and it's our last item. And we have the commissioner back almost. Yeah, I know it's on the back. But this will be brief, right, Commissioner?
It'll be as brief as you want it to be.
This segment.
All right, Mr. Chairman, members of the committee, John Gottfried, Insurance Commissioner. Here to give a brief update on the 1332 waiver and then the healthcare study as well. Last committee meeting, I believe, I mentioned that we were expecting some news very shortly after. On July 31st, we received our final approval, our final federal sign-off of the 1332 waiver we applied for from the House Bill 1106 that was voted on last session. So we are moving forward with our full approval and moving forward for the 2020 implementation. That includes the initiation of the Reinsurance Association of North Dakota, the board. That's made up of a member from each of the four main health insurers in our state, one member from the North Dakota House of Representatives, Representative Kaiser, one member from the North Dakota Senate, Senator Vita, and then two non-voting members from the North Dakota Insurance Department, which is Matt Fisher, who's our company licensing division director, and Crystal Bartuska, who's product filing division director. So Matt Fisher and his team will be the ultimate kind of implementers and administrators of this program. And so he'll obviously be on the board to help guide some discussions. The first meeting will be called early to mid-October to kind of set up some procedure and process and just get everybody activated with the board. So that's the good news. Well, it's all good news here, I guess. I did want to go over some of our neighboring states and some of the other approvals that the feds have seen, just to kind of give everybody some nice context on 1332 waivers. So you'll see the North Dakota programs up there. It's a $47 million program. $26 million of that is coming from the state funds, leading to a 20% reduction on the individual market. And our attachment point is at between $100,000 and $1 million with a 75% reimbursement. Montana's reinsurance program was just approved days ago, and that's a $34.5 million program, $12.9 million from state funds. They've also set aside about $500,000 of that for operations, and that is leading to an 8% reduction. Their attachment point's a little different. It's between $40,000 and $101,000 with a 60% reimbursement. Colorado also was approved in the same batch that we were approved in. Theirs is a $250 million program, essentially $87 million coming from the state funds, 16% reduction in rates. Their attachment point is between $30,000 and $400,000. Maryland and Delaware also have been approved previously, but the three, Colorado, Maryland, and Delaware, are funding their model by re-implementing the ACA taxes that have been essentially paused by Congress. The states are then picking that up and saying we're going to implement that 2.5 or 2 3/4% on premium tax to then fund the program. Rhode Island and Delaware were also approved. Rhode Island's a $14.7 million program. The attachment point between $40,000 and about $100,000 with a 50% reimbursement. Delaware, similar size program, 75% reimbursement. So there are now 12 states that have reached final full approval. That includes Colorado, Delaware, Montana, North Dakota, Rhode Island, Alaska, Maine, Maryland, Minnesota, New Jersey, Oregon, and Wisconsin. That's all in your notes. I went over this kind of fast, but again, just wanted to give some flavor to this. There are a few different avenues that states have gone down, but ultimately it's the reinsurance program looks pretty much the same. It's just depending on you're tweaking the attachment points, you're tweaking how it's funded, and then deciding on what kind of level of reduction you want on that individual market. I'm pleased that we went with a bold option to get to a 20% reduction. I do think that'll pay off in the near term for sure, and hopefully keep, again, some of our citizens on that individual market, or at least bring some of them back. And so I do firmly believe this is a good investment for our dollars to use that. And like I said, comparing to other states, one, we're not alone in doing and implementing this program, and two, of the 12 states that have been approved, there are many more that are looking at this right now. We've been in recent contact with South Dakota and Wyoming and a few of other colleagues about the funding mechanism and how we use it. So it's that was just more of a way of background for you all. As this, we'll be announcing our next year's rates in early October, as we always do. We're encouraged by the rates we're seeing, and we're formulating. So you will likely all be hopefully getting some questions on some of this stuff, and it's good news that we're going to be bringing out. So any questions on the 1332 waiver?
Questions? I just want to compliment you, Commissioner, and your department. This was not an easy thing to achieve. You've been working on it for, I think, about 2 years. And John used to have a lot longer hair on this process. No, congratulations. It's great.
Thank you, Mr. Chairman. And we've got a great team at the department that's done a lot of the lion's share of the work. And also, we're unique in North Dakota a little bit. I think we've been able to not only partner with the legislature and work very closely on this with the interim committee last interim, but our carriers have also stepped up to the table and done a very good job of working with us and helping us through this. I think the goal is to find affordable coverage for everybody out there, and so we've all come together, and it's been a byproduct of that partnership that we've been able to be successful in this. So moving into the healthcare study, if that's all right. This is a slide you saw last time, outlining some of the goals of the study and kind of some of the framework that we're still developing. The chairman mentioned that he'll be likely sending out the RAND study The easiest way to put this is the North Dakota study that we're looking at, the cost of healthcare study will be very similar to that RAND study. It'll hopefully bring similar results that are North Dakota-based, North Dakota-specific numbers to look at where the cost of healthcare is going, where it's been, and if there's anything that we can do, whether legislatively or through other collaboration to help bend that curve down a little bit. Just kind of an update on where we're at on our timelines. The May 15th, we sent out that initial letter. That's been done. We've entered into a contract with our project manager, who is a former insurance commissioner, as well as has done some significant work in the health provider side. So we're very excited about her signing off and joining our team to be a consultant in this area. We're also in the process of receiving the RFPs back from our actuary services firms, many of which have significant experience, again, on the health provider side. And so we're very excited about the direction that we're heading. We're still hitting our timelines. We're confident with that. We will have an October kind of introductory meeting with some of our providers. I wanted to get the actuarial service firm in place to have a discussion about the data set and kind of get that set before we go talk to the providers, so we at least have an idea of what we're looking at, what we were looking for. That meeting, I think, is coming in October 21st, towards the end of the month. But we've set that with the larger providers of our state anyway to have that meeting. So we're moving forward with the kickoff meeting with the actuarial vendor will be on the 7th. Management plan coming out the 10th. Data collection by the end, towards the end of the year. Again, these are the timelines that we're still on, and we're hopefully being able to drive towards that midsummer next summer to be able to bring to this committee a finalized report with some proposed recommendations for you all to consider, to look at, and digest. That is kind of the very brief update I've got. As always, you can contact us for more information.
Any questions for me? All right, John. We'll go to the last item on our agenda, which is a bill draft 21.0013.01, and it's a bill draft addressing guaranteed issue. The insurance department has worked with Jennifer on this bill, and Jen, you want to review it?
You bet. But I gotta apologize here, committee members, I don't have any movies for you to watch on this. As I said last time we reviewed a bill draft, the first thing we're gonna do is start off with our definitions, and then we're gonna use them. As a matter of background, we're in the chapter of law relating to individual health insurance policies. So we're not in the group policies. We are in hospital insurance, so we're not in health policies such as dental or cancer policies, disability policies. We're in individual health insurance policies. If you roll over to page 2, we provide that an insurer that offers an individual health plan shall offer that individual health plan to all applicants as guaranteed availability and guaranteed issue. Now you want to know what guaranteed availability and guaranteed issue are. So I'll go over the first text side and read your definitions. We talk about it offering the plan and the terms of the plan regardless of health status, age, or income. And then we provide an individual health plan may not include a pre-existing condition exclusion for a condition for which medical diagnosis or medical care was recommended or provided before the effective date of the policy. My directives were to work with the insurance department in revising that language that they had thrown together quickly during the session to address the bill that came up with our study charge to the guaranteed issue. One thing that I want to point out to you is that was brought to my attention, there's no application clause on this. If you recall the version we looked at last meeting, there was an application clause saying the language we base this off of. There was some application language saying this law goes into effect if the Affordable Care Act provisions on guaranteed issue, if they ever go away. We don't have that clause on this bill draft instead. It would go into effect, it would overlap the Affordable Care Act. It wouldn't cause any difference because it essentially mirrors what the Affordable Care Act does with the individual policies. If the Affordable Care Act were to go away as it relates to guaranteed issue, our state law would remain in effect. We do not address small group plans. There's some additional protection under the Affordable Care Act for small group plans relating to guaranteed issue. That's not addressed in this bill draft as written today.
Any questions for Jennifer, Senator Elke?
Mr. Chairman, Jen, how does this affect the CHAN program?
Mr. Chairman, Senator, the CHAN program is, I believe, regulated under a different chapter of law, so this...
But wouldn't it make it kind of, why have both things? They basically, the CHAN program is designed for people that can't qualify for regular health insurance.
Sure, I guess if I understand your question, you're saying regardless of this, under today's law with the Affordable Care Act, this is the state of the law, what we're saying in this bill draft today. So today, why do we have CHAN? Is it really required? Is that right?
Well, I mean, if this, what we were just reviewing passes, now you've got another state program that has, basically all the things that CHAN has in it, and you wouldn't really need CHAN.
Mr. Chairman, committee members, if this bill passed and the Affordable Care Act stayed as it is today, our individual market wouldn't recognize any change. There would be no change because the items being accomplished in this bill draft are already being done under the Affordable Care Act. I think that the question is, do we need CHAN today when we've got guaranteed issue through the Affordable Care Act?
Well, you have guaranteed issue, but not today.
We do under the Affordable Care Act.
No, you don't. You only if you have a qualifying condition or at a certain time of the year. You have to I just got married, or I just got off my family plan, or I just,
You're right.
But with CHAN, you can apply for that at any time.
I believe to qualify for CHAN, and I'm going to look for Crystal, although I don't see her in the room. I believe to qualify for CHAN, you've got to have notification that you've been denied a policy.
Senator Lee might be able to address.
I've been on the board of vets in Scottsboro, and yes, you have to have been denied. And really, it's intended for somebody who has a serious health issue, and my impression, and correct me, John, excuse me, Commissioner, but we're really looking at making insurance affordable for people in the individual market by having this application of some subsidy, so to speak, to premiums and so forth. And CHAN is really different. It's also funded in a different way. So and ACA had a high-risk pool, because that's what it is a high-risk pool. And people had the option of going to one or the other, and North Dakota chose to keep its own high-risk pool. Many other states gave up the ones that they had, and we are very glad that we kept ours, even though the enrollment is significantly fewer, because the ACA one had a much smaller provider network. It had higher co-pays and higher deductibles, and I'm missing something. There's another biggie. Anyway, ours was better all the way around. And so it was a much more attractive plan to somebody who was unable to get a policy at any cost from other companies. So they still pay premiums, but there's a basic cost that's covered in that.
And I do understand those differences, but Senator Elke raises a legitimate point. If the Affordable Care Act went away and guaranteed issue was not part of the small group market, and you had a significant health condition and you hit the $1 million maximum or whatever, you go over into this market or CHAN. I mean, you go one or the other because you'd have to. So the beauty of the current plan is they're covered whether you're in the individual market or at the small group market. But should it go away, that would this would stay in effect, and we would have something similar to CHAN. It might be somewhat different because of the funding source, but you would have adverse selection for the plan occurring, and that's a problem. Representative Council.
Thank you, Mr. Chairman. That was the point I wanted to dig into a little bit. The ACA is gone. This goes into effect. That means there's open enrollment any time of the year for any individual, period. Which means this is not going to encourage people to buy health insurance at all. This is going to encourage them not to buy it until their house burns down. If they have a condition, then they're going to go buy the health insurance. So this has a problem about it if we stay with an open enrollment. If we had an enrollment period like the ACA currently has, and after that point, if the individual chose for the year not to enroll, then there should be potential either a waiting period before they could enroll again, or you could apply some pre-existing condition clause. One of the misnomers of pre-existing conditions, everybody says, well, if you have a pre-existing condition clause, you're not going to have coverage ever. That's not true. Pre-existing condition clause simply says that on the day the policy is written, let's say January 1st, if we had a pre-existing condition clause, if you had treatment for an illness or a disease or an accident 6 months prior to January 1st, that condition that you had for that last 6 months is not covered until you're in the policy for 6 months or a year. After that waiting period, the pre-existing condition is covered. So it's really a waiting condition on a pre-existing condition clause that is a pre-existing condition clause. But I'm really fearful about an open enrollment requirement. This I don't think it's going to increase costs.
Senator Mavin.
Mr. Chairman, I wanted some further explanation about who this would actually cover. For example, the small group plans. It appears this would not cover those.
That is correct. They cover farmers. Business operation with one person, or something to that effect, where they're buying an individual policy on one person.
Yeah. And I think one of the things I think we should encourage is to have groups in these kinds of benefits so that we spread the risk. Thank you.
Senator Devon.
Thank you, Mr. Chairman. Maybe I'm still a little bit naive, but there is a cost. And I'm curious if the insurer can rate the individual based on their pre-existing condition, or did they just spread the cost over all of their policy?
Representative Cassidy.
Mr. Chairman, committee and Senator Dever, guaranteed issue means you do not get to ask any health questions. So the insurance company would not know if there was a pre-existing condition or a health condition. You just sign the application and it's issued.
Unless you rate it on other variables, age. Small.
It says you can't. It says regardless of health status, age, or income.
Senator Hogan.
Thank you, Representative Kaiser. Do we know of any other states have this kind of policy and what the implications have been?
Again, every state currently has this policy.
Because of ACA.
Because of ACA.
But anyone have a local state policy?
Well, everyone has ACA.
Everyone has ACA, but even prior to ACA, did anyone have a guaranteed issue? And perhaps we should do, they did. So perhaps we should ask at our next meeting with the insurance commissioner, talk about what other states are doing in guaranteed issue or did before ACA and what the implications were. That might be helpful for us.
It was New Jersey that had a plan.
Commissioner, you've heard some of the discussion, or all of it, I should say. Do you have any comments to make? Because this,
Mr. Chairman,
I don't want to say it was your bill, but
John Gottfried again. Yeah, I certainly have some comments. Addressing Senator Hogan's point first, there was a couple states that did some experiments in this area, I guess, prior to the ACA. It was Washington had it, New Jersey, New York, Kentucky. Needless to say, there was all of those experiments kind of ended prior to the ACA, I think, because some of the discussion that we've had previously, a lot of those and I'd have to do more research on exactly how it looked, but there is, I think Washington implemented a program without an open enrollment period, which led to a spike in rates, and they ended up scrapping that because they weren't able to navigate that enough. And so yeah, there is some I can probably provide more history at the next meeting. Senator Elke's Chan question, it's spot on. I think it's, as it exists now under the ACA, we have 133 members that are still in Chan. And so it has been dropping off rapidly because nobody's eligible for Chan at this point unless you've been denied coverage. So we don't have any enrollment coming into Chan, and the folks who are in Chan are in there because it's a benefit-rich program. It's on par with a platinum level AC. And we did the numbers next to each other, and it's a platinum level plan, so it's a very rich benefit plan. But we're not able to add any new members into that plan. Similar to this, if we kept the same course in place without making any changes to Chan, Chan would eventually it's on a runoff period. Right? But I do believe that part of this study, there's also a look at if there's any changes we need to make to Chan that make it more viable as an alternative to perhaps a guarantee issue provision. Notably in this bill, we certainly agree with Representative Casper's point that there are some provisions that are missing in this bill that we wanted to have the committee discussion on and get some more directive from you all because they are policy decisions, such as an open enrollment period or special enrollment period. What does that look like? Is that left to us to devise the rulemaking process? I would probably be more comfortable with it in the law, but again, that's a committee discussion for you all to have. We would also like to see some ability to incentivize continuous enrollment. And so even if you're switching plans, but if you stayed continuously in a health plan, that there's a benefit there to do that, to incentivize folks to stay on their plan, and rather than having to jump on and off and try to play that game a little bit. And so there's some pieces in here that are missing. I guess we looked at it as a first crack at it, saying, okay, here's the guts. We can add on some other pieces to it that may make it a little more palatable or may make it a little different, but it does affect the overall policy direction of it. And so we're open to that discussion, we're open to that to hearing from the committee what direction you want to go. But this is certainly a good start, and we'd also be curious to hear from our carriers too, because they need to have a big role in this too. They need a big discussion on where this at. I can stand up here and talk theoretically as much as I want, but in terms of what this does to rates or enrollment or membership, that's got to come from the carriers, and that's got that feedback's got to come from them.
Representative Casper.
Thank you, Mr. Chairman. Commissioner Godfrey, did you think about the implication of COBRA and an employee who loses his or her job, are going to lose their health insurance at the end of the month, going to have to go in COBRA with the current employer? All of the employer subsidies for the health insurance is now gone. So could this be an alternative if that person was covered? They could consider applying to this type of a product, because with the 20% reinsurance subsidy, I assume would apply here, they might be able to continue their health insurance for a period of time at a lower price until they found another job, and they could get off and go on to their new employers.
Mr. Chairman and Representative Casper, I guess we could consider that a special enrollment period, right? Or you could have if defined by law, if the loss of employment qualifies as a special enrollment period, we could certainly have that discussion. But yeah, I'd absolutely agree. I think we've seen those folks go into the short-term policies more so than COBRA, because COBRA is generally exponentially expensive.
In the short-term policy, if you got long-term cancer, you're
exactly, and that's in those short-term policies that we've had this discussion with this committee are you don't want to be on them very long, and so. But again, that would become into the discussion of what policy we want. I mean, what do we want special enrollment periods to be? What do we want an open enrollment period to be? And that, again, is discussion we're certainly open for. We're looking for direction from you all and what you want to see this to become.
Senator Madden.
Thank you, Mr. Chairman and Commissioner. What groups would you want included in this provision?
Mr. Chairman and Senator Madden, in terms of, so the direction we went with this is trying to make it, to address the individual market, right?
Right.
If we want to address the small market, I think we're certainly, if we want to make it mirror what the ACA protections are, I think we can probably do that. We just wanted to start from the baseline level to say, here's where we're at.
I'm just wondering if we included groups, if it would create a more manageable system and a system of keeping it sustainable. I'm a little worried if we just stay in the individual, we might not make it sustainable. Just what your thoughts are in that regard.
Well, Mr. Chairman and Senator Mathen, this may be a very vast oversimplification, but generally, well, the group policies are pretty much guarantee issue, right? They come with the employment piece of it, and so if I'm employed, this is the benefit that's offered to me. I think if you start expanding this into that large group area, it really damages it more than it helps it. I think this is more adding a guarantee issue, a guaranteed coverage provision on the individual market, to me, would be more of a safety net than anything. It'd be that if you are out of work, if you're, or whatever life situation finds you and not able to find coverage, you can always find it on the individual market. You can always go buy it on the individual market. And so that, I think, would be, that's solving a problem. I think if we expand it to a larger, I think we're probably creating more problems than we're necessarily solving. And leaving the individual market as kind of that safety net market where, again, whatever circumstance I find myself in, I can always reach out to an insurer on the individual market and find coverage.
Further questions for the commission? Senator Owen?
Thank you, Chairman Kaiser. And John, what about you providing for us at the next meeting some of the possible variables we could consider? Because it's sometimes hard for us to think about them at the time. If you could outline, because you framed them very nicely for us, can you give us that in writing?
Committee members, what I was going to suggest is we'll work with the department and the commissioner and also with the insurers. I think the insurers can give us a lot of good direction that if the Affordable Care Act were to go away and if the state wanted to maintain guaranteed issue, what's the cost associated with it? What kind of factors would they like to have incorporated for underwriting, sound underwriting, to minimize premiums? And then for those people who can't meet those things, we'll throw them in chain or something, do something to that effect.
Mr. Chairman and Senator Hogan, absolutely. I mean, I know we've got more in the room here that have probably got experience in other areas, other states that may also do opposite, but we're happy to work with whoever.
So if that's acceptable with the committee, that's what we'll do, because I think you're right on track on that. All right, anything else? Any other discussion from committee members regarding anything? The next tentatively scheduled meeting date is, Eileen, you want to address the committee, please? I'm sorry, I didn't realize you wanted to come back.
Chairman, committee members, Eileen Tufte. I wanted to make an announcement today. We did hear from the Surgeon General that he's coming to North Dakota for the Main Street Initiative. So if you could mark your calendars if you're available, October 30th, we are hosting the Surgeon General here. He will be the keynote speaker on October 30th. So I'm really pleased to make that announcement today.
Mylin, is that at a meeting here in town at the Energy Center or somewhere, or where will he be speaking?
He will be speaking at the Main Street Summit.
Okay.
And that'll be here at the Bismarck Center, or at the Event Center.
Okay.
Thank you.
Great. All right, thank you for the invitation. All right, the next meeting tentatively scheduled is for the 20th of November. We are going to try and go to Grand Forks, and that might be the meeting we may end up going there. We will have for you, as soon as we can get it out to you, the RAND study. I would really encourage you to read it. I think you'll find it very informative, and it will give us a good sense of direction for us to complement the insurance department on their study. And we'll do some other things as well. We'll have these bills back before you in some modified form for your further consideration. Please look at them. Any suggestions you have, contact myself or Jennifer. We would appreciate it. And if there are any other items that you would like us to address, we still have several items on our list of things to do that we will get through. But please contact us and give us your input. And with that, we would entertain a motion to adjourn. We are adjourned.
Yeah, it's just, yeah, I thought basically what we're trying to do is just make it just a voluntary way, but then with that, and then it doesn't do that. Yeah, and then like we brought up, well, this doesn't have a time limitation and enrollment period. Clearly, like somebody just sat down 10 minutes and scratched it out, and here it is, but it's not thought through at all. I don't think whoever did it really looked at what's the situation and the care after keeping that situation. I don't think they really.
I will. Yeah.
Question number 4, there's different situations, but the problem is before, let's say you had health insurance and you had a pre-existing condition, like you say, anything over the last 6 months, especially as you got older, you got locked into that barrier and locked into that problem. How are you doing? Because as soon as you moved, you'd have to carry your old policy and your new one for 6 months.
See where you want
is.
I don't know if this line's good or not. It's not a kid, right? He's going to be doing that.
And like here, this line was.
You know what? When I was lobbying
we just got everybody covered, then immediately they're worried about, well, then please don't buy it.
And so as another car go in, I thought about it. Did you?
And I can see that. What sort of?
Well, then who's going to watch it?
For somebody who's not.
Well, that's
He couldn't make it out here.
You go to enrollment period.
Yeah.
I don't know. Sometimes it's
audio.
We'll save money.
If somebody's going to say something, they're going to say it.
That's right.
Taped or not, right? Like, yeah. Really?
The hospital writes it off and you pay the cost.
They put them in and they just sit there. So
Let's pay them.
where can I watch your feed, your live stream?
I can't live stream because I don't have enough subscribers. I was going to live stream on YouTube, but I got to have 100 subscribers.
Well, I'll sign up because
Yeah, and what I'm going to do is try to get the list of people that are coming to the meetings and beg them all to subscribe.
I'll tell all my friends to subscribe because it's the dumbest
I
thing
will
on earth
have
if
it.
we're not live streaming. I said, the cameras have been sitting up there for years, just sitting there.
Yeah.
Use them.
I will be posting them anyway on my YouTube, just Marvin Nelson YouTube
on your channel.
so you can see them.
That's fine.
But so if you have some question about a part, and I think what we're going to do, I might post the way I have right now, and then the sound isn't as good, so I think what we're going to do is take the recording and then take the sound file
and put them together somehow. That's actually a good idea, but I mean, welcome to 1999, people. Let's get some.
I get frustrated with it as a legislator, and we're actually studying allowing legislators to remotely participate.
Right.
I wouldn't want to see somebody go to Arizona for 3 months and decide to remotely participate.
No, I get that.
If
but
they're sick or something for an emergency, I think it's okay.
I mean,
but I would do it in IBL when we'd have those rooms full of lawyers from out of state. I'd turn to the person here and go, would it be nice if this was being streamed so you could have just stayed in California and followed this? Because they weren't there to testify.
No, you're just there monitoring.
We paid them to get up.
I today had no, I mean, I was just here monitoring today, nothing a big deal for any client. Well, I mean, some, a little bit, but half has something about, the social determinants of health and such, but it makes sense that anyone, whether it's us or just, if it gets 10 more people involved in the process.
And even when you take notes, sometimes you take the notes and then it's nice to be able to go back and see.
I'd love to be able to do that, or link to the file if I'm writing a report to somebody or whatever. No,
that's where we're looking right now. Is it'll be on my YouTube channel, and then if I can get enough subscribers, I was doing it today, and I thought I could, and it's like I get all the way down, and YouTube goes, "Oh, well, you don't have 100 subscribers, you can't do this."
I have no idea.
So what do we subscribe to? What is it called?
Your YouTube.
Well,
is it just your Marvin Nelson?
Marvin Nelson, my YouTube channel.
Okay.